Chairman Patterson.
Here.
Vice Chairman Davidson. Here. Representatives Ani. Here. Cupps. Fitzwater. Fogel. Here. Gregory. Hafner. Here. Hicks. Here. McCrary. Here. Ritchie. Here. Sauls. Smith. Here. Taylor. Here.
Thank you. We have established a quorum. We will move into executive session. I move that we vote do pass on House Bill 2120. Discussion. Representative Taylor.
Thank you, Mr. Chairman. I have an amendment ending in .03H. It has been distributed. I move for its adoption.
Representative Taylor has moved for the adoption of an amendment ending in .03H. Mr. Taylor, you want to discuss your amendment?
Yeah, thank you, Mr. Chairman. When I presented the bill, I told you all that I would have an amendment to fix some concerns raised by the Secretary of State. This is what we came up with. Be happy to answer any questions about it.
Discussion on the amendment. Seeing none, I move that we adopt House Committee Amendment ending in .03H. All those in favor signify by saying aye. Aye. All those opposed, no. And the ayes have it. You've adopted the amendment. I now move that we roll the amendment into a new substitute and adopt the substitute. All those in favor signify by saying aye. Aye. All those opposed, no. And the ayes have it. You've adopted the substitute. Further discussion. Seeing none, I now move that we vote do pass on House Committee substitute for House Bill 2120. Please call the roll.
Chairman Patterson.
Aye.
Vice Chairman Davidson. Aye. Representatives Ani. Aye. Cupps. Fitzwater. Aye. Fogel. Aye. Gregory. Hafner. Aye. Hicks. Aye. McCrary. Yes. Ritchie. Aye. Sauls. Aye. Smith. Aye. Taylor. Aye. 12.
By your vote of 12-0, you voted do pass on House Committee substitute for House Bill 2120. We will now move to House Bill 2452. I move that we vote do pass on House Bill 2452. Discussion. I have an amendment and ends in .03H. It's been distributed, and I move for its adoption. This is what we discussed last week on Representative Cook's bill. It would exclude certain vaccines. These are pretty specialized vaccines that probably most pharmacists aren't giving anyway. Representative Cook, the MSMA, Pharmacy Association have worked out the language. I think this is a good amendment. It would exclude these vaccines, but the measles, mumps, tetanus, those kind of vaccines they would be giving. Any questions? All right, I move that we adopt House Committee Amendment ending in .03H. All those in favor signify by saying aye. Aye. All those opposed, no. And you have adopted House Committee Amendment ending in .03H. I now move that we roll the amendment into a substitute and adopt the substitute. All those in favor signify by saying aye. Aye. All those opposed, no. And the ayes have it. You've adopted the substitute. Further discussion. Seeing none, I now move that we vote do pass on House Committee substitute for House Bill 2452. Please call the roll.
Chairman Patterson.
Aye.
Vice Chairman Davidson. Aye. Representatives Ani. Aye. Cupps. Fitzwater. Aye. Fogel. Aye. Gregory. Hafner. Aye. Hicks. Aye. McCrary. Yes. Ritchie. Aye. Sauls. Aye. Smith. Aye. Taylor.
By your vote of 12-0, you voted do pass on House Committee substitute for House Bill 2452. We will now move into public hearing. Representative Roan will present House Bill 2607. Representative Roan, please proceed.
Mr. Chairman, Mr. Vice Chair, members of the committee, thank you for allowing me to present House Bill 2607. I am Don Roan. I represent the 149th District, which is made up of the south end of Scott County, city of East Prairie, all of New Madrid County, and the north end of Pemiscot County. This bill was passed last year. Okay. This bill basically will do one thing. It's very simple. We hear about a simple bill up here all the time. This is a simple bill. What this bill will do will allow the casino at Crothersville from having to have a boat to do their gambling on. They will be able to move it inland. They will be within 100 or 1,000 feet of the channel of the river, and they will be able to build a casino on the land side of the levee, protected by the levee and protected by a seawall there in the city of Crothersville. There's a gentleman here who will tell you about what they're going to do. The history of this is that in 2011, that's the year of the big flood that we had down there, the mooring where this casino boat was tied to come within a foot of coming off of the mooring, and they had to hire a tug to come in, put up against the boat to make sure that the boat was going to be stabilized during that time. And so they have getting ready to spend 40 plus million to build this new casino behind the seawall there at Crothersville. The Corps is going to build a brand new seawall, raise it 16 inches, and they're going to spend 35 million to put the seawall up to protect the city of Crothersville, and the beneficiary of this is going to be the casino. And basically, to give you a history of Pemiscot County, it's one of the poorest counties in the state. This is a huge investment in the county. They are probably the first or second largest employers in the county. They have a good payroll. They have probably 300 people working at the casino. They draw from Arkansas, the Missouri, and across the bridge there at Dyersburg to Crothersville from Tennessee. So they have a good drawing. This bill was passed last year out of the House, 133 to 7, and out of committee 14 to 1. But it got tied up in the Senate like everything else does here. And so we attached it to Senate Bill 26 as an amendment. Senate Bill 26 has now got a lawsuit against it, and the people of the casino decided they don't want to take a chance on their bill being drawn out of the Senate bill's legality problem. So they came back to me and said, Don, would you do it again? I said, sure. It's a simple bill. It should be passed. It's for the betterment of the whole community of Crothersville and the Boot Hill. I'll be glad to do it. So I brought it forward to do this. So with that, Mr. Chairman, I'll open it up to any questions that anyone might have.
Thank you, Mr. Roan. So this is the bill that we've already passed. We're just doing it again because of that lawsuit.
Because of the lawsuit, I can address the lawsuit a little bit. It was a lawsuit filed in St. Louis, I understand, because some of the amendments to 26 were not germane to the bill, and they're just scared that they'll pull this one out as being, and then they're in trouble because they have already let the contract. They're ready to build. It's not, are we going to build? They know the company out of Cape Girardeau that's going to build this. They've already let the contract. They're ready to build a hotel complex, gambling complex, redo their restaurant. It's going to be a top-notch casino when they get finished with it. So it's not the idea that is it going to happen. It's already happened. We just want to make sure that they're standing on firm ground and get this bill passed into law, and then they know they don't have to worry about Senate Bill 26 lawsuit.
All right, thank you. Questions for Representative Roan? Thank you, Representative. Witness in favor of the bill. And we will alternate. All right, thank you, sir. Is your mic on? A little green light on? Okay, can you turn it on for us? Any questions for the witness? All right, thank you, sir.
Thank you.
Witness in opposition to the bill? No opposition. Next witness in favor of the bill?
I'll be really fast, Mr. Chairman. James Harris, representing Century Casinos. We're ready to break ground and begin construction May 10th, which is kind of the other reason, which they were kind of indirectly. And so it's not often you have abstract projects that if you pass this bill, the legislation's been passed, we've had approval from the Gaming Commission, contracts are signed, we're ready May 10th to begin construction. We're happy to answer any questions.
All right, thank you. Next witness in favor of the bill. Any witnesses just for informational purposes only? That will conclude the hearing on House Bill 2607. Thank you, Representative. We will move on to the next bill from Representative Busick.
Thank you, Mr. Chairman and committee, for hearing my bill. My bill is House Bill 1798. House Bill 1798 has been filed in reaction to the COVID outbreak of the past 2 years. The dental schools of this state brought this bill to my attention. One of these schools I proudly represent, the Missouri School of Dentistry and Oral Health, which is part of A.T. Still University located in Kirksville, Missouri. A.T. Still is a founding school of osteopathic medicine and the home of osteopathic medicine. This bill is brought forth to give our local dentists the opportunity to assist in the administration of vaccines in the event of emergency. Seeing the need for more avenues of availability for vaccinations in troubled times, this bill offers another venue to get much-needed injections to the public population. Dentists are very highly trained in the administration of injections. They have a much higher level of training than many who are administering the COVID vaccine in today's world. Therefore, I see no logical reason why dentists should not be given the opportunity to be of service to their patients when the need arises. House Bill 1798 does the following. House Bill 1798 allows dentists to administer any vaccine for diseases related to the practice of dentistry. It also allows dentists to administer vaccines that are not related to dentistry in the event of an emergency that arises where vaccines are much needed. Dentists will be allowed to administer vaccines only to their patients unless the emergency administrators see the need to deploy dentists to provide additional assistance in getting vaccines administered to the public. House Bill 1798 sets forth very clear guidelines. Dentists will not be forced to administer vaccines. It's optional to them and voluntary. The dentist will be required to receive training and be certified to give any such vaccines. Within that training, each dentist will not only receive instruction concerning the administration of the vaccine, they will also receive training concerning the proper storage of each particular vaccine that would be administered. Each dentist will also receive training concerning the possible reaction to the injection and signs that would indicate such. Each dentist will be required to review the patient's vaccine record on the Show Me Vac system. Each vaccine or injection administered shall be registered in the Show Me Vac system until unless the patient objects to such registration. If such patient protests in the entry, if a patient protests the entry into the Show Me Vac system, then the administering dentist will then provide a written report to said patient's primary health care provider. Said report will include a detailed list of information concerning injection giving to that patient. So there is several guidelines set out in this bill that would allow dentists to give vaccinations. And I think it's just a bill that's come to its time and needs to be moved forward. It did pass the House last year, but as Don's bill, it got tied up in the Senate and did not get through there. Any question, I'd be willing to answer.
Thank you, Representative. In the pandemic, did dentists give vaccines through an emergency order?
Not
I
this
don't even
time,
know.
no.
Okay.
Not for the COVID, no.
Okay, and then in this bill, they could give dental vaccines, and then they could also give the other vaccines, the measles, mumps.
Yes.
Those kind of,
In
an
the
emergency only?
Yes.
okay. Do they give vaccines now? I don't even,
I
know.
I can't answer that. Now,
Okay.
I've got a person back here that may
Okay.
be able to answer that here.
all right, sounds good. Thank you. Representative McCreary.
Thank you, Mr. Chair, to inquire. Good evening. So one of the questions I have, and maybe it's just because these bills don't normally come through emerging issues, but I'm a little bit perplexed by why the data wouldn't be submitted to the state into the Show Me Vac system. It seems like within your bill language, there's a way for people to not have their medical records available.
Yeah, I think there is a clause though that allows a patient not to allow that to be public information, and so I think.
Well, our vaccine records aren't public information.
Yeah. Well, it just allows for that objection here in that bill. So.
Well, but it's kind of a circular argument, because you're saying that somebody who gets a vaccine from a dentist doesn't have to have it entered into the Show Me Vac system through Department of Health and Senior Services. But then it also says prior to administering, a dentist shall review the patient's vaccine history. So that database is of no use if people aren't actually allowing their data to be put in. So I'm just.
Well, I think what it's mainly for is that somebody wouldn't be double vaccinated, for the same
right,
thing.
but if you're saying that people that get a vaccine at a dental by a dentist don't have to have it put into the vaccine, but yet you're holding up that system through the department as like the place where you go to check things, it really, it seems
Can you tell
contradictory.
me, and I don't know the answer to this, can you tell me, is it required, if a doctor gives a vaccination, that it be entered, is it required for doctors to put that into the system?
I have no idea. That's why I said, this
that
bill.
may be why it's included, but I couldn't answer that question either.
Okay, it just, I don't know. I think that database is only going to be as powerful as people participating in it. So if you're allowing people to get a vaccine and it not be recorded into the system, it seems like that database would quickly be irrelevant.
I can understand that.
Okay, thank you.
Representative Fogel,
To inquire.
please proceed.
Thank you. So my question is, a comment first. I like the spirit of the bill. I think, we need to provide the right level of care at the right time, at the right cost. I think this is a good step in that direction. But my question is, if we're not incentivizing dentists in terms of reimbursement for services, are we going to have dentists that are wanting to participate or wanting to provide immunizations to their patients? Obviously, we know that it's a cost to provide immunizations. You have to store them. You have to keep them refrigerated. You have to pay staff to log them in and out. And right now, my understanding is those CDD codes aren't billable. So my question is, are we also working on the back end to make sure that providers are going to be able to be reimbursed for these services, billing them through MoHealthNet or private insurance? Otherwise, I worry that we'll pass this bill and there won't be a provider base that wants to deploy them.
Well, that's, I think, the reason why it is voluntary, but I think that will be something considered by each dentist to make sure that they have the proper avenue to get that done.
Right, but right now, if a dentist provided a vaccine, they couldn't bill those codes. There'd be no reimbursement mechanism. So my question is, are we also working on the backside of this to make sure that if a dentist does provide these immunizations and they submit those claims to MoHealthNet or to private insurances, they will be able to seek reimbursement for these services?
Yes, I believe that's being worked on. Will be worked on in the process here. The organization will work on that process and make that. Of course, they also do the training, the setup for the training, and I believe they will do that same thing at that time.
Okay, thank you.
Further questions for Representative Busick? Representative Smith.
To inquire briefly.
Proceed.
Just, I guess a simple question is why? I mean, when I read this, I just thought, is this really necessary? It's not necessarily a bad thing, but
Yeah.
is it?
Well, I think there'd be some times where going to a dentist and getting vaccinated would be a benefit, because most people that go to a dentist aren't carrying transmittable diseases, so it might be a safer environment that they could receive a vaccine. And when you have so many, when the process come out this last time, we all of a sudden had a flood of vaccines available and not as many providers available to give those vaccines, and I think this just gives another venue for somebody to get vaccinated. Well, another thing, we're giving them, but we're allowing a lot of people to give them, and so I guess I don't see why dentists couldn't be another avenue, because we're allowing pharmacies, we're allowing, National Guard people to give the vaccinations and things like that. I just think it's another avenue. Yeah.
Further questions? Thanks, Representative. Do we have a witness in favor of the bill?
Chairman Patterson and State House Representatives, good evening. I'm Dwight McLeod.
Is it green? Yeah, you have to really speak into this mic for some
Okay,
reason.
sorry about that. Okay. So this number may seem small until it hits home, killing a family member or loved one. Dentists can help to reduce the prevalence of HPV and HPV-associated deaths. The American Dental Association is the governing body for over 202,000 dentists in the United States. The ADA advocates and supports dentists given the vaccine and campaigning for greater public health and awareness. Relating to dental workforce in the state of Missouri, we have over 4,000 practicing dentists. Dentists give hundreds of thousands of injections daily in the mouth with long and short needles, skillfully done around vital nerves and blood vessels. Of the entire healthcare team, dentists give more injections daily than any other healthcare professionals, but yet we have been prohibited and limited in practice scope to give an intramuscular shot in the deltoid muscle in the state of Missouri. Dentists and dental specialists currently put patients to sleep safely using potent medications in order to do complex surgical procedures, but yet we are limited in the state of Missouri to give a shot in the deltoid muscle. Dentists and dental specialists repair broken jaws, fractured faces, sinus lifts, jaw joint surgeries, and other complex surgeries of the head and mouth, but yet we are prohibited or limited in practice scope to give an intramuscular shot in the deltoid muscle in the state of Missouri. It is quite ironic that pharmacy techs can give injections with only a high school diploma or GED. Continuous education is not required by the Missouri State Board of Pharmacy for the pharmacy technicians. Dentists are important and effective contributors of the healthcare team with many years of training, experience, and lifelong learning. We should not be disenfranchised or devalued for our role in preventing diseases and promoting health. Dentists play a vital role in the oral and systemic connection in controlling infections of the mouth, which improve outcomes of major cardiac, joint replacement, and cancer surgeries, not to mention healthier births and less preterm low-weight babies. Treatment of complex medical patients and practice of preventive health care, such as diabetes and tobacco cessation. Dentists and the medical professions hold shared responsibility over the multidisciplinary diagnosis and treatment of patients with oropharyngeal cancer, many of which really are caused by HPV virus. Yet most dentist practice authority are limited to deliver HPV vaccine and other related vaccines. Dentists can prescribe scheduled substances or controlled drugs 2 through 5. Dentists have a minimum training of 8 years, and for some specialty, another 8 years, a total of 16 years combined. Dentists are required in the state of Missouri to do a minimum of 25 hours of continuing education credits. Dentists may see vulnerable population that physicians do not see, and this is the important part. In the United States, dentists see over 9% of the population, which that number or those individuals may never see another healthcare provider. So let me repeat this again. In the United States, over 30 million people, or 9% of people, see a dentist but will not see another healthcare provider. This is a big gap that dentists can make a significant difference in affecting the outcome or care of these individuals. This is like the size of the population of Canada. The ability to administer HPV vaccine is about health, not wealth. It's professional care and not financial shares. State legislatures should grant dentists authority to administer HPV vaccines. HPV immunization reasonably falls within the scope of dental practice. I am pleading with you to support this bill to halt the rising number of HPV-associated cancers of the mouth, throat, and head and neck regions. Let's work together to increase the low HPV vaccination rate and save lives, especially in the state of Missouri. Thank you, and I'll take any questions at this time.
All right, thank you, sir. Is HPV vaccine, is that really what you guys want to be giving?
That's the primary vaccine that we'd like to give, but in the emergency cases, for example, the flu vaccines and other new emergent vaccines that may come along, we don't want to be excluded from the opportunity and the privileges of giving those vaccines. We're part of the healthcare team, and it's about time we get the respect that we're needed. We take care of a lot of people, as outlined in my testimony here.
And you currently cannot give the HPV vaccine?
We currently cannot give any vaccines in the state of Missouri. Compared to other states where vaccines can be given, over 43 other states, dentists are allowed to give COVID-19 vaccines, and in 3 other states, they can give a host of other vaccines. Now, the goal is not for us to give childhood vaccines. We don't want to do that. We know that these childhood diseases are common, and kids and parents need to take their kids to see their pediatricians and other primary care physicians. So it's outlined in the bill that those are not vaccines that we'd like to give.
All right, thank you. Questions for the witness? Representative McCreary.
Thank you. To inquire. So I think all of us are with you on wanting to do anything we can to eliminate a cancer that's preventable. I mean, that's pretty amazing to me because we don't really have other options like that. But one of the questions I have regarding HPV is the dosing schedule on that. So it's 2 or 3 vaccines, and they have to be given a certain amount of time apart. So, and if the window's not hit right, then there has to be a 3rd vaccine. So can you talk me through how that might work for a dental practice?
So one thing that is very good about dentists and the relationship that they have with patients is we have patients on recalls every 3 months or 6 months, and they come in religiously for their care. I'm sure many of you here are some of the patients. I wish I could go every 3 months. That'd be great. Some of the patients that we treat, yeah. But I think it's understood that between the ages of 11 and 12, and you get 2 shots, and then after age 15, you get 3 shots. And this is also given for older adults. What we're seeing is that older adults who were married for many years are now widowed or separated or whatever the case may be, and they too are at risk. So the vaccine is not only applicable for younger individuals, but also older individuals, middle-aged individuals. They're to prevent from getting oral and throat cancer.
I guess, that's what I'm having a hard time imagining having these kinds of discussions in a dental practice, because you have to convince the parents that a 9, 10, 11, or 12-year-old needs a shot and that they have to get it early before they're sexually active. And I just can't imagine having that conversation in my dentist's office.
Studies have shown that dentists have a good rapport with their
Okay.
patients, and they're open. We are somewhat the psychologists for our patients. They come in and they tell us story, and we spend more time, probably 10 times that amount that a physician will spend with their patient. They're quick in, quick out. We have our patients for an hour, a minimum of an hour, sometimes an hour and a half, depending on the procedure that is being done. So we do spend a lot of time, and we get to know our patients.
Okay. And then I guess what should comfort me is there would have to be training on this. So dentists would be trained on how to talk to families about this and why it has to be done early before the person's.
Absolutely.
Okay.
And as the Dean of Missouri School of Dentistry and Oral Health, it's our goal to educate our students in this arena to make sure that they're fully armed and prepared to work with any state laws and to work with any requirements that we need to put in place to be able to be compliant and effectively access this type of opportunity to be able to help our underserved populations. And that's
All right.
exactly what we'll do.
Very good. Thank you.
All right, thank you.
Thank you. Further questions? All right, thank you, sir.
All right, thanks.
Is there anybody here in opposition to the bill?
Good evening, Mr. Chairman, members of the committee. Chantel Dooling with Missouri State Medical Association here in opposition of the bill. We just feel that a licensed physician should be administering vaccines, and they should be having this relationship. I know that the bill does say over 7, but you can administer any of the childhood vaccines. Can be recommended even between the ages of 7 and 10. So, whereas we appreciate that language, we still can't. For children, they are required to enter into the Show Me Vac. So, giving in here where they don't have to, I'm not sure how that would play out. Federal guidelines did actually allow dentists to administer in Missouri and across the entire nation in the emergent for COVID vaccines. Just doing a quick search of other states, I could not find any, and granted, I was just kind of looking throughout the day to see if I could find any. I couldn't find any states that would allow them to be able to administer childhood vaccines. Now, there was a lot of information about COVID vaccines in emergent situations, but I wouldn't put my life on that. But just doing a search, I feel like I really couldn't find anything on childhood vaccines. I did reach out to the AMA, and they are supposed to get back to me on that. So if I get that information, I'm happy to share that with the committee. This language is not specific to what kind of vaccines that they could administer. And the Dental Practice Act is very specific on the practice of dentistry of human teeth, its adjacent structures, and the oral regions of the mouth. So they're very specific. So we just kind of feel like this is really kind of broadening their scope a lot more than we realize that it is, because they're going far past giving these vaccines of treatment of just oral regions. I understand the HPV and preventing cancer. We definitely want that as well. Dentists are very skilled in what they do. We definitely don't have anything against what they do, and we do respect them very much. After all, oral health plays a huge part in your overall health, and we definitely do not overlook that. But we do not think that they should be administering vaccines, especially when it would be the Board of Dentistry that is approving these classes and everything like that, and not the Board of Healing Arts, in which our physicians have to answer to. So I am happy to answer any questions that you may have. I tried to answer the questions that were being asked, but if I miss one, I'm more than happy to elaborate if I can a little bit further.
Thank you. Questions for the witness? Representative Fogel.
Thank you, Mr. Chair. Just quickly, I think you clarified a question I had. So under the emergency order, dentists have been able to provide COVID vaccines specifically.
Sure.
Have there been an increase in mistakes made when dentists have been administering those vaccines? Is there any track record of that not going smoothly? We had a lot of the same conversation with pharmacists last week.
Yeah. So I get this question a lot, and there really hasn't been a lot of data come out. But also for a malpractice case, generally, like 16 months is kind of the average for a malpractice case, and the entire healthcare industry as a whole has been kind of busy with this pandemic. So we just really haven't seen a lot out, and I hate to say this, but there really hasn't been enough time, I feel like, that we're really going to start seeing that on any realm of the healthcare, not even just specific to this.
Okay, thank you.
Further questions? Representative Smith.
Do you have an issue with pharmacists administering vaccines?
We did oppose that as well, yes. So we oppose that, and for the same reasons. We just feel it should be a licensed physician, and when dealing with children, they should have a patient-physician relationship. And I think when we're talking about this, people so quickly get to looking at the schedule of infants getting their vaccinations and through that. But these vaccinations can be given up to the age of 10. So that doesn't, so no, we had an issue with pharmacists. We fought that too. We didn't love that it went through, but there's really not a lot that we can do about that now.
Okay, thank you.
All right, thank you. Witness in favor of the bill.
Mr. Chairman, members of the committee, Organ Schlemm, on behalf of the Missouri Dental Association, we want to go on record in support of the bill. We did work with the School of Dentistry. They are very great to work with us on all of their issues, and we really like the structure of the bill, the additional training. That's one thing that our dentists definitely wanted included in the bill, and they have that in there. So with that, we are in support of the bill.
All right, thank you. Questions? Next witness in opposition to the bill.
Mr. Chairman, members of the committee, Brian Bernskater here on behalf of the Missouri Academy of Family Physicians to go on record in opposition to the bill. Chantel raised a lot of good points. I will just speak to my own experience with my own child, and the decision about the HPV vaccine was a difficult one, and it was a lot of questions. And it was aided greatly with that relationship of growing up with that doctor and my children. It helped aid that conversation. If I think about having that conversation outside the context of their pediatricians or a family practice doctor, that conversation gets kind of messed up, muddled, and you know, it's just a very different sort of atmosphere. And we're seeing more and more that we're having opportunities to engage in healthcare outside of the doctor's office, which is fine, but there's some things that are very sort of sacred to that relationship. And the conversation about some of these vaccines is one of them. And we think that those conversations should be had with a family physician or a pediatrician or someone on the like. So I'd be happy to answer any questions.
All right, thank you, sir. Next witness in favor of the bill. Any other witnesses in favor of the bill? Next witness in opposition. Any witnesses for informational purposes only? All right, that will conclude the hearing on House Bill 1798. Thank you, Representative Busick. We will now move on to public hearing on House Joint Resolution 77 with Representative Sassman.
Thank you, Mr. Chairman, Vice Chairman, committee members, and thanks for allowing me to present House Joint Resolution 77. For the record, my name is Bruce Sassman, State Representative in the 62nd Legislative District. House Joint Resolution 77 is a constitutional amendment that would reset term limits from 8 years to 12 years in the House and reset term limits from 8 years to 12 years in the Senate, for a total of 24 years of service. The resolution also establishes 4-year terms in office for members of the House of Representatives. On November the 3rd, 1992, Missouri voters approved by a margin of 75% an amendment to the state's constitution by limiting the number of years a legislator may serve in the General Assembly. Prior to this provision, Missouri had no legislative term limits. 15 states currently have some form of term limits. 10 states have imposed consecutive limits, and only 5 states, including Missouri, have imposed a lifetime term limit. H.J.R. 77 is related in subject matter to 2 Senate joint resolutions. This House resolution was drafted independently. In preparing the resolution, I polled the diverse spectrum of our society. There seems to be overwhelming support in favor of expanding the term for representatives in the House and extending term limits from 8 years to 12 years in the House and Senate. As the committee knows, building relationships is a key to the success of state legislators. As a state representative, it's crucial we build relationships with our constituents. It's also important for us to develop relationship with industries and business in our district and other elected officials in our district, including school boards and city councils, county commissioners, fire districts, housing districts, hospital and nursing home boards, and from each other. Expanding the term and term limits will help us develop better relationships and at the same time improve the efficiency, strength, and stability of our office. Now, I know I'm preaching to the choir, but we all know building experience, learning how to navigate this system, and strengthening the relationship takes a lot of time. Just when we are in a position to offer the best of what we have learned and the best of ourselves, our service to the state is over. We will always have term limits in Missouri, but in my opinion, the current terms are too short. It is my sincere belief, and the science suggests, we will have a better government in the state of Missouri when our elected officials can use their extended experience to benefit the public they serve. Voters in every election cycle will continue to be the driving force in limiting the terms of our legislators. A couple of science notes prepared by Most Policy Initiative offer some highlights and illustrate my point. States with shorter legislative term limits tend to rely heavily on lobbyists, special interest groups, and state agencies to provide the information needed for policy making. There is also evidence that states with shorter term limits spend more money and encounter greater difficulty making long-term and efficient budgetary decisions. I thought it was interesting to learn that term-limited states have experienced higher legislator turnover rates after enacting the limits, and especially with a higher turnover in the House. Research from Missouri has shown legislative term limits are also known to decrease policy expertise, decrease institutional knowledge, and discourage specialization among the members. In an analysis published in the State Politics and Policy Quarterly, in states with shorter term limits, members were incentivized to delegate more power to the leadership. I would welcome any questions.
Thank you, Representative. Are there states out there with bicameral legislatures where both houses have 4-year term limits?
Where both houses have 4-year term limits?
Isn't that what your bill, 4-year terms?
4-year terms. I can't answer that.
Okay. And then there have been bills out there where you can serve 12 years or 24 years in one house or the other, just as long as it adds up to 24. Just to be clear, this is not that.
This is not that. This is just 12 years in each house. And this, I thought, simplified that. I know some people, or some of the bills have suggested we could serve 16 years or 20 years with varying terms in either the House or the Senate, but it just seemed simple to understand for the voters to maybe wrap their head around when we just serve a fixed term without adding on years to different branches or different chambers.
All right. Questions for the bill sponsor? Representative Ritchie.
Thank you, Mr. Chair. Representative, you and I had a conversation about one of the details in your bill. Wanted to see if you had any thoughts subsequent to that conversation with respect to extending the term from 2 to 4, understanding that historically our philosophy of government with the quote-unquote lower chamber being closer to the people, 2 years, even at the federal level, with the Senate having an extended term so that they had more of a deliberative element. They were farther away from their next election. What what thoughts have you had since our conversation on that particular topic?
I'm glad we had that conversation because I did consider that. And if I understand this right, the framers of the House, the framers of the Constitution thought the House would be more responsive to the constituents. The framers also believed, and this is, I think, will bring a smile to everybody's face, the framers also believed the Senate with longer terms would offer the calm and stability of the legislative body. I'm not sure that the framers, if they were looking at a situation we're in now, would agree with maybe their earlier decision. And as far as constituents are, let's see, as far as the lower house serving 2-year terms and being more responsive to the constituents, I get that, especially when the framers were not aware of the communication devices that we have now. But I think everybody, regardless of the term they serve, have the ability to be in contact and communicate with their constituents.
I would love to be able to be in a position where I did not have to, on a every 2-year cycle, be back up for reelection. I do think that there's going to have to be some more discussion, because if you don't have any kind of distinguishing characteristic between the House and Senate on terms, there's virtually no, there's really no difference at that point. It actually benefits us tremendously because we have a very small footprint compared to theirs when it comes to the population they represent. I appreciate the spirit of the bill, and certainly on the term limits component, I think that there could definitely be some work done, and would be supportive of a reassessment of what term limits need to be. I just think that based on the wisdom of the framers of the way we were structured, even at the state level, that a 2-year House term does accomplish what they were setting out. But it's definitely an interesting conversation, and certainly am open to ongoing thoughts and discussions on the language here. So,
okay.
Thank you.
Thank you. I would encourage us not to refer to the Senate as the lower chamber.
Oh, did I say that?
Oh, I'm just kidding.
Oh, okay.
Representative Davidson.
I think some of the tumult in the opposite chamber might be accredited to the fact that there are so many elections currently going on as well. I would say the wisdom of 2 years to 4 years and elections drawing representative, whether they be a senator or a House member, to that particular constituency should be heavily weighted. I just want to echo a lot of what Representative Ritchie said. I really like the legislation. I like a new conversation around term limits in Missouri. I do think there is, unfortunately, value, and I say unfortunately because I'm about to go through a whole nother door knocking campaign that I feel like I just finished not long ago. But there is value, and it does draw me nearer to my constituents as well. And so if you're open to that sort of conversation, I would love to continue it as well. I really like this HJR, though. Thank you.
Okay.
Representative Sauls.
Yes, thank you, to inquire.
Proceed.
Thank you. So I think, I understand some of the communication that's going on here, but I also think in a way we are different because we're smaller districts too. So it's not like, I think that just naturally the House is a more personal, I guess, or I don't know what word to use. But we are, because of the fact that our size, 37,000 constituents versus 100 and whatever it is, 100 and something thousand. I think that I guess that would be my argument to that. But my question is that this also would make it so that, the way I'm reading it, it's every 4 years, so there's no, like the Senate has a cycle, right? So odd years, and even, would that be your intention too, or do you intend to, all House seats would be every 2024 and then 2028?
No, we would also be on a 2-year cycle, just because we're on a two-year cycle now. And if we just fast forward 4 years, we still continue to be on a 2-year cycle. Of course, everybody fast forward the same number of years. So those of us that would be in our 6th year and our 8th year, or our 2nd or 4th, it's still 2-year cycles. So if you add that extension, we still would have to have 2-year elections every 2 years to fill the seats.
I don't know that I'm tracking that. And if that, and maybe I'm just misreading it, but to me it says beginning 2024, members shall be elected to 4-year terms. I think if that is your intent, then I think you would want to add something in there that says, just like with the Senate, even numbers and odd numbers, or something to that effect, so that you're doing 4 years like that. Maybe, and if somebody,
No, I had the same, I tried to go over the same logic in my head, and I tried to create this spreadsheet, and I understand what you're saying. It looks like, well, then we don't have elections in the House every 4 years, and that was not my intent. And as I penciled this out and tried to create that scenario, I made the rationale in my head, and I wished I could articulate that now, but it does. We continue to be on a 2-year cycle, even though some of us might be serving for.
Maybe have a staggered schedule.
Yeah, we have a staggered election now, so wouldn't we
Yeah.
continue to have a staggered schedule? I would explore that further, but that was my intent, and I thought I had that mentally prepared. But if I'm wrong, I'm happy to admit it.
Yeah, it may need some more tweaking.
Okay.
So, any further questions? All right, thank you, Representative. Any witnesses in favor of the bill? Any witnesses in opposition to the bill? Any witnesses for informational purposes only?
Hello, Chairman Patterson and members of the committee. My name is Dr. Elena Bickel, and I represent the MOST Policy Initiative. The MOST Policy Initiative is an organization based here in Jefferson City, and we offer nonpartisan information to the members of the Missouri General Assembly. Term limits place restrictions in 2 general ways. One is called consecutive, which means that after you have served a specific number of years at either of the 2 houses, you have to take a break, and then you can go and be elected again. And there are the second category, where they're called lifetime limits, like the one we have in Missouri, where you are basically banned, as they call it in the literature, from running again for an elected office. In the literature, I'm just going to confirm some of the findings that Representative Sussman mentioned. In the literature, we do see that term limits that states with term limits tend to experience higher legislative turnover rates after enacting those limits. We also see that although it is difficult to fully assess the particular effects of state-level term limits, research from the state of Missouri has shown that term limits in the state have had significant effects on the institutional expertise and specialization, which has decreased. The concentration of power in party leadership relative to the governor also tends to decrease. And then the power of interest groups to push for policy that favors the organization, which tends to increase. We also see in the literature that proponents of term limits tend to say that this type of practice, if institutionalized, may increase the diversity by encouraging traditionally excluded groups like women or racial and ethnic minorities to run for a public office. However, studies have not found a statistically significant difference in legislator diversity between states with 2 term limits and no term limits at all. And your question, Chairman, I think you asked if there are any states that have 4 years limits like we do. So basically, right now we have 15 states that have some sort of limits. We have 10 states that have consecutive term limits. And in those, we have some that have per House, like 8 years for the House and 8 years for the Senate. We have in Michigan where we have 6 years of limit for the House and then 8 years for the Senate. And we also have states that have restrictions in total. So like it doesn't depend on how many years you spend in each of the houses, but you need in any proportion to not spend more than 12 years in Arkansas and 12 years and 24 years in Louisiana and Nevada. So I'm open to any questions if you have any.
And then can you tell us, are there any states that have 4-year terms?
No.
Okay, so we would be sort of, experimental. We'd be a state doing an experiment if we did this.
Oh, so you mean for the House?
Yes.
For 4 years? Well, not so. I guess the smallest number of years that I can see in the literature is 6 years for the House.
But that's not a term. That's probably 3 2-year terms is the limit, correct?
I will
No
have to
state
look
that
into
has a
that. Yeah, I will
4-year
have to look into that.
Okay.
That's probably the case.
And really, in Michigan, you can only serve 6 years in the House?
In Michigan, yes, 6 years in the House and 8 years in the Senate.
Okay. All right. Further questions? All right. Thank you, ma'am. Thank you for being here today. Thank you, Representative Sassman. We will now move on to public hearing for House Bill 2605 with Representative Gregory. And just so everybody knows, we will have 2 hearings on this. We'll end today, and then we'll come back next week and have more testimony. Representative Gregory, please proceed when you're ready.
All right. Mr. Chair, members of the committee, for the record, Curtis Gregory, Marshall, Missouri, House District 51, Saline County, Pettis, and parts of Johnson. Today in front of you is House Bill 2605. I think in the interest of time and for the witnesses that are here today, since we're doing a 2-part, I'm going to try and go through this kind of as quick as I can, go through those questions and let these witnesses testify since many of them have a long drive to get back home. So this bill was brought to me as a problem. As many things we're dealing with COVID, there's a lot of crises going on out there. And as we work through those, we got to try to do the best we can. One of these crises that are going on out there is in healthcare facilities, specifically nursing homes, some hospitals, is dealing with staffing issues. I'm sure we all heard that in the news, and we saw it, we lived it. And when we go to these nursing homes, a lot of us have had residents or grandparents, relatives, so on and so forth, friends in these nursing homes. We want them to provide the best care possible. And we want them to be there. Well, with these staffing agencies in these facilities, there's been an exorbitant amount of cost being absorbed by these facilities. The nursing homes, a lot of them run off of a fixed revenue, being Medicaid, Medicare. There is no, they can't go out and charge, $500 per day and change the costs that they go through. And so they're running as short on staff. I am appalled at some of the survey results that I've seen from some of the staff that has come in on the agencies. So some of the things that this bill would look to do with the agencies. We want to make sure that staff provided are who they say they are, credentialed properly for the care that they are provided to do. We want to make sure that the staff adheres to facilities, policies, and procedures like all the other staff employed by said facility to provide care in the best interest of patients. Because when you go in to see your grandmother, your grandfather, or your aunt, your uncle, you want to know that they're getting taken care of as best they can. And I'm not saying that all nurses, travel nurses, nursing home nurses are bad, because there's very, very good ones out there. I received that care when my relatives were in nursing homes, and I greatly appreciated the job that they did. And we also want to then ensure that these facilities can continue at a sustainable rate, meaning we want to make sure that they can stay in business. There's already been nursing homes, long-term care facilities that have closed down. Why are we in such this crisis with residents in nursing homes? Well, because the baby boom generation is coming of age. It was something I learned in one of my past jobs dealing with life insurance, that we have one of the largest populations of folks reaching an age where they're going to need to go into assisted care facilities, nursing homes, long-term care facilities. So we want to make sure that they can continue to operate and provide the best care possible for our relatives, friends, and family members. And so after this was brought to me and I heard some stories of examples, I did what any good person would do. I called my mom. But I called my mom for a very good reason, because she does happen to work at a nursing home in Concordia, Missouri, where many of my family members have gone to and lived out their last days. And I just kind of run down the list of some of the issues that has been dealt with, and it was rather astonishing. And I've got many witnesses behind me that can speak to a lot of these. I'm just going to read off a couple of examples here. For instance, this facility, we have had many instances of agency staff leave during their shift, showing up late or not show up at all, not adhering to facility policy or procedures. Also, the quality of work is predominantly subpar, as no personal investment or oversight for quality. Overbooking of staff by agency, then no one shows up. Been told this is a strategy to hold shifts so an agency competitor doesn't fill the shift. Staffing agency CNAs sign up for open shifts, then call in the sick the day before. Approximately 75% of the CNAs that have signed up for shifts call in sick. And again, these are different facilities, just some survey answers never provided to me. No call, no show, leave early, come in late, do not follow facility protocol. And so facility protocol would be an instance of, like, if a mask is required, saying I don't have to wear a mask. And then at that point, if a regulator or surveyor would be in the building, that nursing home is then liable for a fine because of that employee. And there's many, many different examples, a lot of them repeat. And so I think we're just kind of at a point where we need to look at this issue and take it seriously, because at the pace we're going right now, I firmly believe that many more nursing homes and long-term care facilities could go out of business, and then we won't be able to provide the high-level quality of care that we all expect for the residents that at that stage of life need it the most. And so with that, at this point, I will stop talking and answer as many questions as I can, and then I'll turn it over to the witnesses behind me.
Thank you, Representative. For the underlying problem, why can't we just let free market principles work? What, are we operating in a free market system here? Is it? What do you say to that?
Well, I would say with you, that was one of my initial first concerns when I saw this. If you'll see on one of the last pages, we talk about initiating a rate cap. My answer to that would be, it is not truly a free market. It would maybe be a free market if everybody was, so to speak, paying out of pocket and had the means and the ability to do so. There are some people out there that are able to do so and do. One of the gentlemen I work out with back home, like, they were paying out of pocket for all of the care for his mother in the nursing home. But as what I was told, that 90% of clientele in some of these facilities are operating off of Medicare or Medicaid. And so those programs are dictated how much they can then pay per resident per day. And if I fudge some of these answers, they'll be able to help me. But that's my understanding, because I ask those same questions, that it's a set reimbursement to that nursing home. And so if it's $100 per day and there is an amount charged that is way over cost, the revenue to that nursing home for that day could be ate up within the first 4 hours of the day. And then said facility is then deficit spending. So the best example that I was given was, imagine you've got a coffee shop and you're sitting there going, man, I really need 4 workers today so I can open my doors. You have the option whether or not to open your doors. These facilities do not. So if they are short 4 staff, they're going to be out of compliance and they will incur fines. And so that is where these supplemental agencies come in extremely handy, because they do. But as if any good thing, if it gets exploited, there's going to be bad actors, and I'm not saying that's happened. And again, I want people to know that I support the nurses and I support the job that they do, and not every single one of them has done a bad job. But in your coffee shop, if you can't find 4 workers, you're just not going to open, you're not going to make money that day. But if you have someone comes up and says, well, I'll provide you your 4 workers, but they need to pay $40 an hour, you can just laugh and say, man, I'm just going to close my doors. I'm not going to open. But I would be open to paying them 20. And they say, well, wait a second. Don't close your doors. They really need to work today. Can you do 25? And at that point, you might say, well, it's a Friday afternoon. I think there might be a lot of people coming in to buy coffee today. We'll go ahead and pay them $25 today, and we'll open our doors. That is an example of a true free market, whereas this one, I believe, is not, because we as a state with the Medicaid programs and I guess the federal government with Medicare is only paying so much per patient per day.
All right, thank you. Questions for the bill sponsor? Representative Hafner.
So, gentlemen, to inquire, Mr. Chairman.
Please proceed.
Gentlemen, good evening. We've had some multiple conversations on this, and having a wife of 36 years, as I've told you, and multiple folks that are sitting in this room, I'm really torn on this one. I think it's really been exacerbated by the COVID situation, not only with my wife working in a hospital down there in Cass County, but I've got a sister, North Kansas City, that spent her entire adult life working in nursing homes. And I've seen it from both sides. And all I can say is I'm torn both ways, because I've seen it both ways. And we're just going to have to wait, listen to some of the experts back here. I'm really concerned with the free market principles that the chairman brought up. I'm concerned with adding on additional administrative requirements to these third parties that are trying to help within the healthcare industry. But I've also seen it where parts of that are broken. And we got to provide that accountability. So all I can say is we just got to wade through this and have continued discussions.
Yes, and thank you for those conversations. And I will say, I'm definitely not a proponent of expanding government. But when I found out that there is currently no, I guess, statute for these companies to register with any kind of government oversight to make sure their ducks are in a row, quite frankly, I was a little bit shocked. When I also learned that if one of the staff nurses come in and doesn't adhere to facility guidelines and rules and regulations, that there is no recourse to the staffing agency. If a nurse comes in and is not credentialed properly as, so to speak, advertised, and there were to be an adverse event, then the onus falls completely on the care facility and not on the staffing agency. And I was appalled. I was generally appalled. And that's why I decided to move forward with this and hope to find a solution that can work for everybody and for the better of the residents of the great state.
Thank you. Representative Davidson.
So that last piece that you said is something that I want to get into more, and I hope we have a robust conversation in the room about it. Is there really no recourse for these nursing homes, for instance, to say, hey, this is a price gouging situation, this is a false advertisement situation? I'm curious to look into the statute, and I've been trying to actually look into it over here and reading as quickly as I can. And it's RSMO 407, and I hope that someone with more expertise than me can maybe comment on this later. But to any extent that you know, are there not already within statute processes that could be taken advantage of to maybe address these problems without creating a further statute and more regulatory?
As in the price gouging, is that what you're referring to?
Mm-hmm.
So my one-person staff and I sat down and did some research on that. And I've also heard there is another bill that has been filed to where some of the price gouging laws could apply in this situation. I'm not by any means going to say I'm an expert in that. That is just what I had heard and been told and what we had found out.
And I'm just wondering generally if there's a problem presented before us, if perhaps some sort of liability changes might be a better path to improvement. I think I sit with a lot of the committee. I think I sit with you in terms of.
And for instance,
a lot of, go ahead.
For instance, there's been times where if one of the staff nurses comes in and something happens, I can't remember the exact stories, but just say they're just completely not following any kinds of orders, just causing more mayhem than they are good, and they are sent home. the way I understand it, the facility is required to report that they were understaffed for that shift, and then they inquire
Are they required to
fine because
report
of that.
Is that to the state or is that to the federal government?
I would assume to the state, but I hope people behind me are taking notes to better answer that question.
Yeah, I mean, if it were the state, then a solution I might present is leniency on that front. You know, understanding that there's shortages and that we're in a position where maybe you're going to have to deal with a 80% load of nurses or whatever the case may be. But yeah, I guess I'll save more questions for folks behind you. But thank you.
Yeah, on the flip side of that would be patient safety and nursing ratios, which is a big deal.
Exactly. For instance, you know, the Veterans Nursing Home in Warrensburg, I think it's like a 150-bed facility, but they're only operating with around 80 residents because of staff shortage. So they are at capacity, air quotes, but they're sitting there with almost 80 empty beds or more.
Further questions? Representative Ani.
Thank you. To inquire. So part of this legislation talks about requiring these staffing agencies to carry malpractice insurance. Are you aware of any instances of where that would be necessary, or how? Like, I guess I'm curious. Are there other non-medical entities that are required to carry similar malpractice insurance, or how does it work? Because I'm not really familiar with that, and Chairman Patterson maybe could provide a little bit more information as well. But can you speak a little bit to that portion?
I think with what we're looking to do with a lot of these is just provide parity. If I were to own a nursing home and I had to register, you know, with the state and carry some of these things, then I would think that it would make sense for some of these agency companies to, for parity's sake, follow down along that line. That way there would be some of that liability shift, so to speak. And I'm pretty sure I did see a couple of examples in here where there might have been an issue where that could have come up. And like I said, we've got plenty of people behind us that might be able to answer some of those questions in more detail.
Thank you.
And thank you. We'll do Representative Ritchie, and then let's get to the witnesses because I think they'll provide good value. Representative Ritchie.
Thank you. I'm just going to ask my questions now, and it can shoot over you if you desire, because I know we've got another hearing in the future. Yes, but just for time's sake, what would be interesting for me to know is would it not, if we have situations where a nurse doesn't show up that signed up for a shift through one of these platforms, and this question is kind of like for the crowd, right, whomever it may end up being, are there not disciplinary features to those platforms to where the nursing home reporting back to the platform that person was a no-show, and the platform then would kind of give that person a tick in terms of, hey, you know, if you do this, we're dropping you from the platform and you don't get to participate, right? I mean, I'm kind of thinking along the lines of like Uber platforms and things of that nature. I mean, you've got an Uber driver that never shows up, then at some point that person's not, their reviews tank, right? So is there not a solution in that respect in terms of some of these things? On the matter of defrauding, you know, I think you'd mentioned something about nurses that aren't qualified or aren't certified, they show up and they're not doing what they claim they can do. Would it not be better to come back against that individual for a kind of fraud? The platform wouldn't necessarily be at fault. The nursing home's not at fault. It's the individual that misrepresented his or her qualifications, right? And I would imagine that the association that represents nurses would be probably the first one to say, this is not good because we don't want our reputation sullied by somebody who's defrauding a process that we find valuable. So that's another thing that I think would be a good question is there not a greater importance to hold the individual who is defrauding the platform and the nursing home responsible if a fine is assessed against a nursing home. Would that individual then not be culpable in some way legally, or should they then, if that mechanism doesn't exist, maybe that's the thing you create? The question's already been asked about malpractice. Is an internet platform entity, are they culpable for malpractice? I mean, how do you do that? And then I do think that there is a price gouging protection that already exists if you get into those situations. This is a very complicated bill, very complicated, and I feel the tension that's been communicated already. We need to be respectful of the fact that we have service providers that are charged frontline, taking care of people who are the most vulnerable, and their situation has been exacerbated by the fact that we have a massive labor issue right now with wage inflation, the likes of which we haven't seen for a very long time. I don't know that that's the fault of a platform. That's the issue that we're facing as a society right now on labor and wage inflation matters. But there's got to be some kind of workable solution that both sides can come to. It's just going to be really difficult. I'm just going to say it's going to be really difficult to get a bill of this magnitude with the components that's in it passed through the General Assembly, knowing the General Assembly that we have. I mean, the idea of getting people to support price caps, and it's just tough. I absolutely get the challenge and the problem that we're facing, but there's got to be some other solutions that are accessible that both sides can find reasonable here. But those are just questions right now that I'm trying to process. I'll be quiet now. You know me, I could take a lot of time talking, so I'll be quiet. Thank you.
Let me address the staff shortage issue. One of the other problems in the survey, I think it was 75% of facilities surveyed have had staff hired away by the staffing agencies, thus exacerbating the problem. 75% of the surveys or facilities had staff hired away, which adds to the issue. Now, I'm sure there's agencies that do things right. I know there's facilities that have done things right because they have seen what's going on and they have tried raising the rate that they pay to stay competitive, but they have just continually been getting outbid.
Yeah. I think on that, I mean, my inclination in those types of situations, like a platform that would be similar to an Uber platform, isn't hiring people. It's a platform that individual nurses or other medical professionals look at and say, if I want to fill some open time, I want to pick up a shift here or there, they're doing that willingly. And at the end of the day, the challenge that we're facing is driven more by this this wage inflation thing that's just like catching us all in a really tough spot. And at the same time, a labor shortage. I don't know that I would feel comfortable telling individuals who are making personal choices to how they're going to contract their personal time, whether it's through a formal hire or working through some kind of an application like this. I don't know that I would feel comfortable saying you can't make that choice because it's hurting your former employer. You know what I'm saying? I mean, it's just that's the challenge, right? I mean, I don't know. Again, I don't know that. I'm not going to blame the nursing home,
right?
And I'm not going to blame the platform for the shift of labor interest. It's the individual that then makes up a collective movement, if you will, of people that are saying, hey, I've got options now that I've never had, and I've got an opportunity like I've never had to chase, significant increases in pay that I've never had access to before, and I need to put bread on the table, right? I mean, how do I say no to that? But at the same time, we've got to protect our nursing homes because they don't have the ability to set their prices, right? I mean, they're absolutely fixed in terms of their revenue stream. So both sides are going to have to sit down and come up with some kind of a workable solution, because both sides have legitimate concerns. And thank you for the consternation, man. Because this is pressing my analytical gray matter. So thank you for that. You're stretching me.
Well, it has done the same thing to me too. I feel like where we're at with some of this language is extremely good position, in my opinion. Just trying to find the parity piece of it. In a line in here, I believe it is on page 3. Hyphen number 3, you'll see not restrict in any manner the employment opportunities of its employees in dealing with agencies, because there has been instances where nurses go to work or sign up with an agency, and then cannot, when they want to go back, are said the hospital they left has to then buy out a non-compete clause with said agency. And I can't fault anyone with wanting to make more money. Absolutely not. I mean, if I could go take a job and make, double what I'm doing now, by all means. But this is being taken advantage of, in my opinion. And the non-compete clause in some of these contracts, I would almost maybe question if nurses know that some of that is in there when they go to work for them. Because if I live in Marshall and I work at the hospital in Marshall, and then I go travel for a while and I want to come back to the place I started in Marshall because that's where I actually live at, and then I find out I can't because of something I maybe didn't know I signed, I think we need to look at that long and hard.
All right, thank you, Representative. Let's move to witnesses in favor of the bill and alternate.
Mr. Chairman, members of the committee, Nikki Strong with the Missouri Healthcare Association, and I have some things I want to go through kind of to back up what Representative just went through about why we're pushing the bill. I also have answers or responses to most of the questions that were asked, so I'll try to cover them all. So if you'll bear with me, I do have a lot of information I do want to share with you. First, when I start my testimony, I want to say two things. The first thing is that, look, our nursing homes are not opposed to paying higher rates. And I think that Representative Gregory did a great job of explaining, but I'll further explain to you the problem with that. When you have $100, you can only spend $100, period. The cost of care in our facilities right now costs us more than what we're being paid. We're doing everything we can to offset, shift things around, and pay for it. This dynamic has created a significant issue with most of our facilities. So it's not that we're opposed to paying more for the services. I mean, look, if there's anyone that deserves to be paid more, it's the CNAs, the CMTs, the LPNs, and the RNs that have been on the front lines for 2 years dealing with all the regulations we've had to deal with, the mandates, the close down to visitation, everything we've done. These folks have been through hell along with our residents, period. So we're not opposed to paying more, but we have to be able to live within our means, and that's part of the problem. The second thing is we're not proposing this legislation to eliminate agencies, whether they be on the platform or whether they be a traditional agency. But what has happened, and this started pre-COVID, COVID has exacerbated the situation. So this has been brewing for a while, but COVID has exacerbated the situation. And what started this was the inability to find staff in nursing homes, because nursing homes are one of the most difficult environments to be able to recruit staff in. If you know the work that these folks do every day, it's very, very difficult, very difficult. But you can go to a restaurant or flip burgers or work at a gas station and make what some of these folks are making with work that's not near as difficult. So again, we're not opposed to paying more, and we certainly don't want the staffing agencies to go out of business. But there's got to be something done because this is unsustainable, period. The first thing I want to kind of get into, just to kind of show you the breadth of the impact to our industry. So we've been, I mean, this is the number one issue that I'm being blown up by our members daily, and it has been for some time. So we sent a survey out to some of the facilities and quizzed them or surveyed them on what they're paying. So the first sheet in the documents that I think were probably handed out to you guys show you what the rates are that we're paying currently. Now, this is averages based off the response of 180 facilities. We have approximately 500 facilities in the state of Missouri. So the average in-house facility rates you'll see in this first column, going from RPN, LPN, CMTs to CNAs, $31.15 an hour, $25 an hour, $16.40, and $14.65. These are average rates that facilities are paying across the state for those in-house positions. An average regular staffing agency rate is the next column, $60, $51, $31, and $33 for those same positions. As you can see from those numbers, it's nearly doubled what we're paying in-house staff. Then look at the third column. The third column are the average premium or crisis staffing rates that staffing agencies are charging for those positions. $80, $64, $44, and $43 an hour. So we're going from this to many times up to the numbers in red. And these are all responses based on prices that these facilities, and I say this because these facilities continue to increase all the time, from 2.7 to 2.15 of 2022. The next page, we asked specifically the facilities, what has your financial impact been paying these staffing agencies? And we asked for 2021 calendar year, because we know that these rates have increased, fourth quarter 2021, and then the last month, which would have been January of 2022. So the total costs are in the bottom middle column. 2021 calendar year for 80 facilities that responded to this question, $48,319,152. Fourth quarter of 2021, $14,742,557. And then last month, January, 80 facilities paid $5,547,843 in staffing agency costs. If you break that down and average that out to a monthly cost, there's been a 30% increase in what we're paying staffing agencies in just 1 year, going from $4,026,000 to $5.5 million. And as Representative Gregory had alluded to earlier, 77% of the facilities are reporting that they're paying the premium and crisis rates out of the facilities who are using staffing agencies. And then finally, again, we deal with the issue of poaching staff within the facilities out, and 75% of the facilities state that they've had staff poached out of their facility to work for a staffing agency. The other piece that I won't get into detail on, but out of all the respondents to the surveys that we sent out, 88 facilities responded in-depth detail of all the issues that they have, from care issues to showing up, to leaving mid-shift, to not showing up at all, to getting in altercations, all the multiple issues that they deal with from a staffing agency perspective. Again, I'm not suggesting that everyone that works for a staffing agency is bad, but there are bad apples out there. And some of these issues, too, are caused by just not understanding what the care needs are of the residents. Long-term care residents are very complex. Every resident has a different need. You know, do you have wound issues? Do you need to be moved? Do you need to be taken out of your wheelchair sooner? You have therapies. You have different medications. You have different behaviors. You have, and the list goes on and on. Other folks here can tell you about the different care needs. There are also indirect issues staffing agencies, our facilities are experiencing there. And then finally, some other, the third piece is issues that have been brought to our attention, specifically about some of the use of the platforms that we've talked about before that are a little bit different than what they experience with a traditional staffing agency. Again, I'll let you guys go through that and look at that in all your free time to deal with that. One more thing that I want to point out to you, and this kind of alludes to the free market piece of this and the costs that we're incurring and why such a complicated piece of legislation has been filed. You guys have heard, and especially those of you who are on the budget committee for years, us coming up and talking about the underfunded Medicaid rate. Our skilled nursing facilities have been operating under the same rate that was set 35 plus years ago when our reimbursement plan was adopted. We've only increased that rate based on incremental, across the board, global per diem increases that are approved by the General Assembly. The problem with that is it's not capturing what the real costs are that our facilities are incurring, and it's not paying those costs. We submit cost reports under penalty of perjury as a participant in the Medicaid, Medicare program. We have to do this to MoHealthNet every year that shows what our costs are. Our reimbursement plan says what we are reimbursed and what we can be and what is an allowable cost in there. So today, as I sit before you, we're working on rates that are 35 plus years old. I can't remember exactly when the last plan amendment was put in place, but I'm sure some of the folks behind me can. So to give you an example how underfunded the rate is, we're operating on average right now on a rate that's $42.44 underfunded. That equates to $369,824 that we would need to rebase our rate to pay us what we should be paid based on what the cost reports say we should be paid. In addition to that number, we've gone through, because right now the state currently only has 2019 audited cost reports. So we've gone through and forecast looking at cost reports post-pandemic or since 2020, since the pandemic hit. Our increase in labor cost, in-house labor, this does not include the use of agencies, has increased $141,344,333. So a significant amount, almost $145 million. That, again, does not include the increase to staffing costs. If you look at this sheet to see what some of these facilities, you can kind of do the math and see where we are. So when you look at that, you add those numbers together, you don't add up what the increased cost to staffing is, we're already operating $500 million under what our costs are. That might not sound significant to you, but when you look at what our entire appropriation is today, it's around $1 billion is what our entire appropriation is. I'm very grateful for the work that the state's doing to try to get our rates back to where they are. So I'm not being critical of the work that the Budget Committee is doing this year. But I point this out to show you how critical it is and how we aren't a free market. These facilities that I represent are doing everything they can to keep their heads above water, to keep the doors open. And this staffing crisis has been probably the worst impact. It is now the new pandemic for us. It's not going to go away when COVID goes away. It's going to continue for the next couple of years. And if we don't figure out a way to regulate this or rein in these costs, you will not have these facilities there. They are going to have to close down. I'm aware of at least 5 facilities that have closed down since February 2nd. I think since the December 31st, I think there's been another 5 facilities on top of that. It's coming. It will possibly be a tidal wave. And if these costs continue to plague the facilities, we're not going to be able to keep up, period. Some of the other things I kind of want to point out too, just showing you kind of, I gave you a global view, but I'm going to give you an example of 3 nonprofit facilities and some of the staffing agency costs of fourth quarter 2021. So facility 1, nonprofit nursing home, $651,258, fourth quarter 2021 in staffing agency costs. Facility 2, $575,774, fourth quarter 2021 in staffing agency costs. And then $850,704 for another facility in staffing agency costs. So the numbers are significant and it's unsustainable. That's the staffing piece. That, I hope, explains the free market aspect and why this isn't free market. If we could turn to our consumers and we could say to our consumers, hey, this is going to cost us this much. Sorry, I've got to raise your rates. We would, but we can't do that. 70%, approximately 70% of the residents in our nursing homes are paid by Medicaid. Another approximately 20% then are Medicare. The rest are private pay. There is no offset. This is the reality. Those are the numbers. A couple other things just to kind of touch on, and then I'll answer a couple of the questions. Quality of care of our residents is very important. The new payment methodology, in fact, aside from the importance of providing quality care, but our payment methodology that we are talking through and reforming to will include value-based payment, which is a quality payment that our facilities will be obligated to, as part of their Medicaid rate. So our ability to be able to provide quality care, our number one ability has to do with our staff, period. Staffing is what provides that quality care. When we don't have, one of the issues with agency staff is, as I alluded to earlier, they don't know the care needs of the residents. They're not there long enough to learn the care needs of the residents. Long-term care residents have many underlying conditions that are very difficult. The resident in room 1 has completely different issues than the resident in room 2 and 3 and 4 and 5. When you have people that are in and out, in and out, in and out, they don't know those care needs. They can't provide the appropriate care, period. That's going to affect our quality ratings. That will affect and continue to affect our reimbursement rates. Representative Gregory alluded to survey issues, and this is one of the questions that was asked. So the answer to the question, do we have recourse on a staff, agency staff, that does something that would give us a citation or an immediate jeopardy or whatever the citation may be? No, we don't. Do we have to hire that person back? No, we don't have to hire that person back. But we've heard time and time again grotesque examples of staff, whether they be from the platform that you've talked about before or the traditional staffing agency, abuse, telling residents, I wish you would die. In that situation, what a facility is required to do is immediately terminate the employee, report to the Department of Health and Senior Services, and the Department of Health and Senior Services has to come in and investigate that complaint within 24 hours. When our facilities do that, they usually come in, they've done everything they're supposed to, they got rid of that staff member, but they're still getting an immediate jeopardy. They're still likely going to get a significant civil monetary penalty. They are on the hook for that, and they have no one to turn to. And the civil monetary penalty is not from the state, it's from CMS. So we could do whatever we wanted to do with state statute and say, you're responsible for this payment, but we can't. We're responsible for the payment. I've got many examples of abuse situations from folks that have dealt with. Some of the folks that are here will probably testify to that fact. So the regulatory environment is very tough for us. We have two masters to answer to. We have the Department of Health and Senior Services, and we have CMS. And there are times when the Department of Health and Senior Services and CMS don't agree. But CMS trumps Department of Health and Senior Services in whether or not we are cited in certain situations. And there is no sympathy for this was a temporary agency staff, whether it be from a platform or whether it be from a traditional staffing agency. So we don't have any leeway. Staff is staff, and that is it. On the platform, when I think one of the questions you said, when someone does something wrong, can you make a click or something? You can, but on the platforms that we're using now, the click is do not rehire, DNR, do not rehire. But, and I think again, some of the folks that are going to come and testify from the facilities will tell you, that's only seen by their company. So that company knows, hey, this person came in, they were bad, we're not going to do that before. But if your facility ABC in West Plains, Missouri, you don't know that facility EFG in Jeff City had a bad experience with this employee. In fact, I'll give you an example. There was an employee that was hired by a nursing home in Southwest Missouri. That person had stolen identity. They hadn't gone through the proper checks. That facility they found, that individual that they had received from a platform had worked in a hospital and a nursing home prior to that, and none of them figured out the stolen identity. Background checks don't pick that up. So what we hope to accomplish in this bill is to bring some sort of parity between the regulatory environment that we have to answer to, that we're liable to, and we have to deal with through this bill to the staffing agencies, whether it be a platform or not, who are providing staff to us and don't have those obligations. One of the other issues I want to address too, and this kind of goes back to, I think Representative Ritchie, you had this question about giving the employees the ability to be able to choose where they work, whether they want to go and work full-time in a facility or want to be able to travel around. We don't disagree that there are situations where that needs to happen. You have some people, I'll give you an example, that might be a full-time employee in a facility, but want extra work, so they would want to go on a platform and be able to do that. The problem that we have is that agency staff that do that maybe decide, hey, you know what, this platform thing's not for me, so I'm going to go back and have a full-time employee. They've been prohibited in their contract with the platform from coming back and working in the facility. Likewise, the facility is prohibited from hiring them to come back in. In fact, in the contracts for one of the online platforms, a registered nurse, if a facility hires a registered nurse from the platform that wants to come in and be a full-time employee, the platform charges $8,500 to the facility and said, you can have that person, but you have to pay us $8,500. An LPN is $6,000. A CMT is $4,500, and a CNA is $4,500. So we have to actually pay the platform to get that worker to come in, that worker who wants to work full-time in the facility and provide consistent care. So we don't have the ability and the freedom in a platform situation, or, and that's a similar situation in just a regular traditional staffing agency as well. Likewise, I guess we're talking in talking about the platforms. I don't really see a big difference. The difference in a platform and the traditional staffing agency is that you're online, picking them online, as opposed to reaching out to a traditional staffing agency. We're still paying the platform. We're not paying the staff the platform provides. We're paying them directly. We're also paying them when the individual doesn't show up, or I'm sorry, if we cancel on them. We're also paying them, like I said, if we decide that, and they decide that they want to come work for us full time. So I don't see a lot of differences in the platform. It's similar to Uber, but what it creates is it creates a mechanism for these staff members to shop rates and to go and to say, hey, I'm going to sit here and I'm going to hold out to the very last minute. I'm going to leave you hanging even though you don't have anybody to care for that resident because I can make more money over here. Well, I don't fault anybody for wanting to make more money. But at the end of the day, our nursing homes have one obligation, and that is to the care of their residents. And when you're in healthcare, you know your moral obligation, and your moral obligation is to the residents that you serve. And this model does not work in that situation where you can just go and you can run and you can leave those residents hanging. Likewise, when they don't show
It
up.
seems like what you're saying is you operate in a heavily regulated environment, and then over here it's the Wild West.
Correct.
And that's what you're asking for, some sort of
Correct. We need to level
parity.
that out, some parity.
Okay.
Absolutely.
Yeah, I mean, it's a very tough situation.
It is.
Questions for the witness, Representative Fogel.
Thank you to inquire.
Proceed.
Oh, okay. So a lot of the conversation we had today was regarding the financial repercussions that this has on long-term care facilities here in the state of Missouri. So my questions are pretty much, I want to get to the heart of, do we have information or data that shows that these long-term care facilities are operating at a deficit? What percent of the long-term care facilities that we have in the state of Missouri are for profit? What percent is not for profit? And can you provide any data that this is truly a problem? And having some informal conversations with some colleagues, it sounds like we have different opinions on what some of these long-term care facilities, what their financial reality is. And so that's my first question. My second question, looking through this, is this specific to long-term care facilities, or would hospitals or other healthcare entities be included as well?
So I'm only representing long-term care facilities, nursing homes specifically.
So we may
this
have
way-
some
yeah,
more
this has-
conversation.
Yeah, you'll have more conversation with hospital. I'm not
Okay.
going to speak to the hospital piece. So,
Absolutely.
So to answer your question, yeah, we are required to file cost reports every year that are filed under penalty of perjury that outline all the costs in the nursing homes. Those are filed with MoHealthNet. They're not our reports. They're filed with MoHealthNet. MoHealthNet keeps them. I think that you could probably reach out to MoHealthNet to get your official answer on how upside down the facilities are. And, you know, to your point, and I want to address this, the point about how there's scrutiny or disagreement over our nursing homes and how bad off and how bad things really are. You know, we have nursing home owners that have a lot of other businesses. I mean, quite frankly, I have nursing home owners that have, one in particular has 40 other businesses unrelated to long-term care. And that person individually, and I'd be happy to have him call you, is putting $250,000 to $300,000 into his facilities every month to supplement it. And he calls me and he's like, I'm not doing this anymore. But if he doesn't do it, there's no one there to take care of his residents. This person cares for, in particular, some of the more difficult behavioral residents. So I understand the aura around the nursing home industry, but this is real. Our Medicaid rate is one of the worst in the country. And I've yet to find, I don't want to tell you it is the worst because I haven't been able to poll all 50 states, but every state that I have polled, I can't find a state that has a Medicaid rate worse than the state of Missouri at this point in time. So it is real, and I'm happy to get whatever data that I can, but it's on record, it's public, MoHealthNet has it, every facility has to file that.
Thank you so much.
Further questions, Representative Ritchie.
What would you say is the typical experience? I mean, I have no reason whatsoever to challenge the validity of the statements that the facilities are identifying as far as the very frustrating challenges, problems with temporary nurses coming into their facility. Is this the typical experience? I mean, is this, 10 temps coming into the facility, 6 of them are creating these kinds of frustrations? Or, I mean, is this typical? What would be the typical experience coming from the 80 facilities that are trying to figure out how to survive in this context?
So I would say yes. I would let the facilities speak to that specifically. But what we're hearing on a day-to-day basis when they're reaching out to us are that we can't find them. We're getting text messages, hey, I'll come work for you, but I'll only work for the premium rate because I need a new car. Or and I think some of them will show you and have that. I mean, I get it. I mean, I want a new car too, but I can't pay. If you look at the premium rates versus the regular rates, we can't pay that. So I think it's the cost. I think it's the no-shows. I think it's the leaving mid-shift. I think it's the inability to be dedicated to what you're doing, if I'm putting that correctly. So the quality of work, typically on average, not everyone, has gone down.
Okay. So then what you're describing, as to the best of your ability to know, because you're dealing with the information coming to you, and I understand that, what you're indicating then is the norm is well below the quality that should be occurring when nurses are coming in to fill shifts as temps.
I would say I wouldn't single out nurses. I would say staff, agency staff.
The RNs, LPNs seem to, so there are more, but the only ones I've been hearing, from are nurses. So my apologies there. But so the norm is that of those 4 staffing positions, the facilities are saying the product, the service that we are deriving is subpar in the norm.
Yes.
Okay. Is there, and I realize when you break this out, it may not actually turn out to be a whole lot of money for a particular entity, but if the total cost over the last year, for instance, is $48 million that's being spent for agency expenditures, for staffing, would it not then make sense for a particular nursing home to say, we're going to try something different? We're going to take the dollars that we're spending on temp service, and we're going to reallocate that and increase wages for staff as an incentive for longevity, if you will.
They've done that, and I direct you to one in particular. There's a chart in here. This goes to the experience. And
I'm sorry, Mr. Chair. I know that we have time issues, but this is a really.
We're just going to keep going.
Yeah, this is just a really big issue, and I don't want to.
Right. So to answer your question, so we've got 2 things. First and foremost, it's kind of a vicious circle, right? So I'll give you 2 examples. So I had a facility reach out to me, send me a note, and said that the CNA went to them and they said, hey, I've been recruited by the staffing agency. The staffing agency is going to pay me $19 to $20 an hour. However, I'll stay here if you'll pay me $19 to $20 an hour, and I won't go to the staffing agency. Okay, well, you're talking about a CNA. That $19 to $20 an hour in this rural facility was almost double what they were paying that CNA before. So if you go and you increase that one CNA, what are you going to do with all the rest of your CNAs?
Yeah, that's. I'm not insinuating that the idea would be to but yeah.
But then the other piece of this is then once we do that, then the agencies will come in behind and say, okay, well, I'll give you another $1 on top of that. And it becomes this vicious circle that we can't, because then they'll just turn around and they know we have to have the staff, so they'll turn around and they'll put it into their price caps. Another example that some of the facilities have tried, they tried to do their own internal staffing agency. Well, we're going to do this, we're going to charge this, we're going to try to level it out. They couldn't compete with the staffing agencies either. And I thought that was included in one of those examples, and I was trying to find that because all those examples were written by facilities specifically. But that facility tried that, and they had to stop the model because they couldn't keep up with it.
Well,
And
Ms. Strong,
yeah.
Representative, let's hear from a witness in opposition, and then you'll be back next week, correct?
Yes.
So let's hear from a witness on the opposition, and then if you came here to testify today, the committee will hear from you. So we're going to just keep going and hear from all sides because it looks like there are strong feelings on both sides.
Good evening. My name is Felicia Hampton, and I am a member of the Missouri Nurse Association, and I serve on the Advocacy Committee. I have been a registered nurse for almost 20 years. I have worked in healthcare for over 30 years. I currently train nurse assistants, and I prepare them for certification so they can go to work in a nursing home or a hospital or in-home and take care of residents and those that are ill. As an educator, my wages are minuscule compared to what I can make as a registered nurse. Thus, I supplement my income by working agency. Most of my career, I have worked agency. I started out in 1997 as an assistant, a nurse assistant. And then I went on and became a registered nurse, and I started working agency in 2006 as a registered nurse. Working agency has afforded me the opportunity to stay at home with my children and work during the hours that was most comfortable for me and my family. Not only that, when my children had the opportunity to participate in activities at school, I could be there. And this was important for me. I want to go ahead and talk about, I have 3 daughters that are also agency nurses. They work full-time for long-term care facilities here in the state of Missouri, back in St. Louis, but they also have to use agency to supplement their income. One is a certified nurse assistant. $8 to $12 an hour is just not enough money. It's not enough. So we don't have an issue with caring for our residents. We don't have an issue with that. What we have an issue is with when the Cle gas bill or Spire calls and say, we need a payment. That's the concern. I also want to talk about that I have friends that work in agencies. They work travel. They work here in Missouri. And it's not an issue of money on every level. We have to address those improper working environments, less than standard working environments that we work in, working in long-term care. And so that is a concern that I have as well. It's not that we're on a quote-unquote paper chase, right? Money chase. We're not. We're seeking, in some situations, like for myself, was just seeking to be in an environment that is standard, less than, other than substandard. We went from nurses went from being heroes during the year of the pandemic, right, to some of them were unemployed because they refused to take the vaccination, to now we're focusing on, quote unquote, capping the pay, or what we would say, putting a bill rate on what an agency can charge. I think the focus should really be on having adequate pay across the board. $8 an hour to $12 an hour is not enough. As a CNA instructor, I am proud to tell my students, hey, when you finish this particular job, it's not about the money. However, once you get so much time in, if you become 1 year of experience, then you're able to go and make a decent wage. And that's important to me. We have students that are going off to college that are going to become registered nurse, medical doctors, physician assist. Working for substandard pay is something that we need to address. And I can say as an agency nurse, we give quality care. I'm not speaking for everyone, but I'm speaking for those that I've worked with. Currently, we have different agencies that come into the facility where I take my students to do their clinical rotation, their internship, and I can tell you that the staff are excited when they show up because there's a gap when you have to work short. I talked to a resident today to say, hey, we just don't have enough help. And so that agency is there to fill that gap. The issues that have been brought to the table on tonight, that what they spoke about, well, when they show up late, they don't call in or they're absent. That is not a staffing issue. That is a healthcare issue. That is an issue. You could work at Jack in the Box and have those same concerns. That is something that we need to take the time to do some professional development, possibly, and raise the morale. But that's not an agency concern. So that's what I wanted to come share with you all tonight. And that's all.
Thank you, ma'am. Thank you for being here. Questions for the witness? Representative Sauls.
Yes, thank you, to inquire.
Please proceed.
Thank you. So, I just want you, I hear what you're saying, and I truly do empathize. I'm curious as to your thoughts, as what was alluded earlier, that with regard to the Medicaid, because let me say one more thing. I think one of the big problems is that I think probably a lot of us on this committee just don't I think we see the issue in both sides with this, right? I mean, at the end of the day, I absolutely think you should be paid more, right? I think most people in this room probably feel that way, but I think the other position with regard to this being with the Medicaid, right? Like this is what we can pay, and I think we're coming up a problem with that. So I personally I think we should raise that, but I'm just curious as to what your thoughts are to that argument, specifically with regard to that argument.
Well, my personal opinion, perhaps we should talk to Medicaid and ask them to raise their rates. Maybe we should find the funding for that, because nursing staff, the certified nurse assistant, the nurse, we're needed. We're needed, and we still need to make a living.
Like I said, I truly do empathize with you, and I absolutely am for you making more money. So
yeah.
I think it's just that's the only comment I had is I'm curious about that, but I'm in favor of that as well. So
thank you.
Thank you.
Yeah, I think we should talk to and see how we can get, because even in with in-home health, the fees that they're given, it's like what, $16 an hour. And for these agencies, it's just not enough. We need to look at the budget and see how we can adjust that. I also wanted to address the situation where you said, you were asking, is there some policy in place for if an agency person or aid staff do something? Yes. If an agency staff come into a facility and they say something like, I wish you were dead, or they do something that is against the policy, we all still have to live by that nursing standard, right? And so that facility cannot fire them. They can say do not return. They can DNR them. However, they would report that to that staffing agency, and that agency would deal with that nurse accordingly. They have not only fired them and suspended them, but they have also turned them into the State Board of Nursing if that needs to be. So yes, there are some systems in place that allow us to say there's a certain level of standard that is set in healthcare. And we abide by that, whether I'm working agency or whether I work for a facility. All right?
All right. Thank you, ma'am. Thank you for being here. Next witness in favor of the bill.
Good evening, Mr. Chairman, members of the committee, Bill Anderson.
Your mic on.
There we go. Sorry about that. Bill Anderson, on behalf of the Missouri Hospital Association, want to go on record in support of House Bill 2605. So this issue with nurse staffing agencies is one that we hear about from our members every day. It's one of the big issues driving concerns out there. There was a shortage of healthcare workers prior to the pandemic. The pandemic has only exacerbated that. We employ about 38,000 nurses across the state in our hospitals. We have a turnover rate that's greater than 20% right now. The situation, and let me be clear, we support our nurses. They're a critical part of our care team. We can't do what we do without them. The issue that we have is with the practices that these staffing agencies, and not all of them, but some of them, are creating, where we're seeing staffing costs jump 15 to 20% within a year, and in an industry where staffing is about 50% of the budget, to have a jump that big in this short amount of time is putting a big strain on the hospitals. It impacts hospitals across a continuum, from the large systems down to the small rural hospitals. For example, MU Healthcare this year, they're spent 7 times what they had budgeted for nurse staffing agency costs, in the millions of dollars, down to the small hospitals, the hospital in Marshall, where the sponsor's from. They've spent almost $750,000 more over their budget on nurse staffing costs. And so those cost increases in that time, when reimbursement is generally fixed, is hard to absorb. And as as the chairman mentioned, we are very highly regulated. There's no regulation on the other side, and so we're looking for ways to kind of even the playing field there. We're really concerned about our rural hospitals. Based on 2020 numbers, our rural hospitals are operating at a 0.41% operating margin, and over 53% of them operate with a negative operating margin. So these types of big changes is especially acute on our rural hospitals. So we're looking for solutions. We're trying to help our hospitals be able to manage through this crisis of staffing. The one, and Representative Davidson is gone, he mentioned price gouging, and there are price gouging things in statute under the Missouri Merchandising Practices Act, but the existing statutes are not really set up to contemplate this type of service being a price gouging issue. So there is also legislation on that out there as well. We just want to impress on the committee the importance of getting some assistance on this front. It's a big concern for our hospitals and a big obstacle for a lot of hospitals going forward. So I'd be happy to answer any questions.
Thank you. Questions for the witness. Representative McCreary.
Thank you. Thanks for being here. So I think all of us are realizing that the Medicaid rates being locked in at from 30-some years ago is a bad thing. But I'm envisioning a hospital where there are some things that are handled there that aren't necessarily Medicaid locked in. So like elective things, where there's ability to raise the price a little bit. But then ultimately we're all paying for that anyway. So I just walk me through the economics of how that would work.
So, on the situation, we definitely have lots of and it depends on which hospital you're in, what the payer mix is. So, you have Medicaid and Medicare, they're both fixed, generally under the cost of care. I think it's 66 cents on the dollar for Medicaid and about 87 cents on the dollar for Medicare. But also, even within, say, commercial payers, those rates are negotiated, so there's not the ability in a short duration to change rates midstream.
That's helpful.
Those rates
so
have to
if the cost of health care assistance like nurses, LPNs, that kind of thing, if that goes up, it doesn't.
There's no immediate thing that you can do on prices.
Maybe it would come into play later in renegotiation, but not short term. So. Okay, very good. Thank you.
You can charge the insurance company whatever you want. They're going to pay.
They're going to pay what
you have.
Yeah, that's right.
Any other questions for the witness? All right, thank you, sir.
Thank you.
Next witness in opposition.
Good evening. I'm Heidi Lucas. I'm the director of the Missouri Nurses Association. Thank you for taking time tonight to hear from us. So a couple of things. We are opposed to this bill for a number of reasons, but the first and foremost is let's not go after the nurses, right? They're not the problem here. Nurse pay is not the problem here. we should be paying our nurses a fair wage, and after the last 2 years, I think all of us in this room can say that they very much deserve it. I think we could come to a compromise whenever we're talking about agencies, either capping the amount that the agencies can make on that. So if they are paying, 20% of what they're charging the healthcare facility, and 20% of that goes to the nurse and the rest is something that they keep, okay, let's have a discussion about that. But I think, going after our nurses and their pay is not the answer. This is one of the things I've heard from our nurse members a lot over the last couple of weeks. There's similar talk being done at the federal level, and they are angry about this. And, any work that folks are doing, it's okay to make more money as a nurse these days. They are a finite resource, and they should be paid as such. So I don't think that is the answer we are looking for at this point. Also, I really do feel for the nursing homes. I understand that they are in a different situation than a lot of the large hospitals, but the way that this bill is written, it is going after not just agencies who are working at nursing homes, it's also talking about hospitals. So I think that is an issue as well, particularly when you have administrators at hospitals making millions and millions of dollars, and our nurses are making $50,000 a year. CNAs are making $20,000, $30,000 a year. Those aren't the folks who you should be going after on this, and there's the salaries that you shouldn't be going after this. So I'm happy to answer any questions.
Thank you. Questions? Representative Ritchie.
One question. Okay. I have a real problem with talking, what from...
It's okay, I do too.
Yes. I've got a story for you, but I'm not going to chase the rabbit. It goes back to my childhood and talking to teachers all the time. So from your perspective as an association, what is your thought, or how would you suggest the disciplinary element be addressed if the normal experience, as it's being described, I mean, I have no way of knowing, how accurate or inaccurate it is, but if the reports are accurate and the normal experience is that individuals in your profession are consistently providing substandard service, how would you suggest that be addressed?
So first of all, we don't represent CNAs.
So just the people
for
that
nurses, for CNAs, I know they are regulated by the Department of Health and Senior Services. The nurses are their licensure is through the Board of Nursing, and so they have mechanisms there that if substandard or unsafe care is being given, then a report can be made to the Board of Nursing, and disciplinary action can be made that way. That's for LPNs, RNs, and APRNs are through that. So that there is a mechanism to do that for that. CNAs, again, they're through the Department of Health and Senior Services, so you would have to go through them to figure out that portion of it. But for our nurses, there is a process already in place for that.
Thank you. Representative Fogel.
Thank you, Mr. Chair. Do these staffing agencies employ full-time employees with benefits, or is it all part-time flexible?
So that's a good question, and my understanding is it depends on the agency. After some time, you can get benefits depending on the agency. So sometimes the agencies do say, after you've worked so many hours a week at assignments, then we do offer benefits that way.
And I see some head noddings behind you. So my concern and my question is, I think this has already been echoed by my colleagues, but we all agree that nurses, CNAs, individuals who are tasked with caring for our state's most vulnerable in long-term care facilities or are sick in hospitals, we all agree should be paid a good wage. My concern is we still have people who are going to need full-time jobs, who are working, day in and day out in the same long-term care facilities in the same hospitals. And I'm worried that we're handicapping our ability to support those nurses as well that maybe don't have the flexibility or don't have a secondary income and can work or operate in this new kind of format where it's more of a PRN situation. So when we're talking about making sure that nurses are paid a living wage, I want to make sure that we're also remembering that there are people, we do have to have a high percentage of our nurses who are employed by the hospitals or employed by the long-term care facilities. And it's what's disappointing about this conversation, I think we can all agree, whatever, regardless of what side you're in, it feels like we're pitting these two interests against each other in a way that we shouldn't be, because all of us are supportive of the individuals who are caring for our grandparents, our parents, those that we love. And I don't want the conversation to get to a place where it feels like we're picking and choosing which nurses or which CNAs deserve to make a good rate. But I want us to keep in mind that we do rely on the labor that's showing up day in and day out in these care facilities and these hospitals. And we should be having a similar conversation about how to increase their pay, which I think everyone in this room agrees with.
I agree with you 100%. However, this bill isn't the answer to that. So I would say, you know, whenever we're talking about that, why are folks leaving their positions for other positions? I mean, it's not just about the money, right? So are other reasons. That's a much deeper discussion than I think what we have time for today about why people are choosing to go agency. And it's not just about the money. It's about working conditions, fairness, how they're being treated, hours. You know, it's a very complicated situation that further, you know, is a problem right now with the nursing shortage and healthcare shortage. But this bill is not the answer to that.
All right, thank you. Thank you, ma'am.
Thank
Please
you.
remember to fill out a witness form. Next witness in favor of the bill.
Chairman, members of the committee, Jorgen Schlemmer on behalf of the Missouri Assisted Living Association. After kind of listening to the testimony, I'm not going to speak about the financing of the issue, and I agree with the witness that was previously up here on this is not the nurses versus the nursing homes or the hospitals. I do think, though, that it is the staffing agencies to some regard and against versus the nursing homes and the hospitals. When a staffing agency goes into a nursing home and recruits their staff, they have to not only recruit that staff, they have to recruit the responsibility that goes along with that. And that's the piece I think that seems to be missing, is when they recruit the staff from the nursing home or they recruit the staff from the hospital, they say, hey, wait a minute, we don't want any of the responsibility that comes with you working for that facility. If that person doesn't show up to that facility when they're an employee of the nursing home, and the Department of Health and Senior Services comes in and says, hey, guess what, you have too few people, the nursing home doesn't get to say, oh, I know they're an employee, but it's not my fault. But yet that's exactly what the staffing agencies want you to believe is it's not our fault. Yes, it is. When you actively recruit people from nursing homes and people from hospitals, and then you say it's not my fault when they don't show up, it is. You need to take on that responsibility. When they do something wrong in a facility and they're an employee of a nursing home facility, the nursing home doesn't get to say to the family member, you know what, that was the employee. It's not my fault. Yes, it is. And it should also be the fault of the staffing agency. When the person is in a facility and they are injured, that staffing agency should be covering them on workers' compensation. They should, in every regard, be acting as if they are the employer because they recruited them out of an employment situation, and now they're going to them and saying, guess what? The government makes you buy my product. I don't care how much you take, you pour into Medicaid and you say, guess what, nursing homes, we're going to fully fund your costs, because you can always charge more. If the government makes you buy the product, guess what the cost is going to be? As high as you can possibly make it. So the idea that Medicaid rates can fix this, it can make it better. But you know, when Nikki was talking about if we had more money, they could probably pay $25 an hour for some staff. But then guess what? They get recruited for $30 and $35 and $40. Oh, you're going to pay them $50? We'll pay them $55. It doesn't matter. When you mandate a product has to be purchased, the cost is infinite. And I believe that one thing that this committee absolutely needs to do is tell the staffing agencies, if you're going to cause the problem that has been caused by raising the rates, you have to accept the responsibility that goes along with that. And that's everything from that employee. They don't show up. And the idea that it's not us, we're just a platform. When you recruit somebody out of a facility, you're not just a platform. When the facility wants to hire that person back and the platform requires the facility to pay $5,000, $6,000, $7,000, $8,000 to do that, you're no longer just a platform. Those types of contractual arrangements then automatically attach you to some responsibility. Medical malpractice, they absolutely have to cover them for medical malpractice. When you have a family member that comes in and says, you know what, we think that nurse or CNA has done something wrong, the facility should not be responsible for that contractor. The person that sent them there should absolutely have to do some screening process. When they show up and they don't have proper credentials, that's the staffing agency. If you're going to offer a product, you better make sure that the product is as you advertise it, not as they advertise it, because you have the relationship with the facility, not them. I do believe that once you start putting some real responsibility and requirements on these staffing agencies, I do believe that you're going to see a lot of the bad actors disappear, because that is not what they're here for. They are here to raise the rates, collect the money, and then you know, we have a lot of friends in this building, but if you look at some of the other legislation that has been filed, it is, that's not my fault, that's not my fault, that's not my fault. And they want to push everything to the facilities that hired the person or where the employee worked in the first place. So I do think that that is a beginning. I do also think that there should be, I love the idea that I just heard. If you want to raise the rate, you can only charge a certain premium on top. And if you're gonna charge the facility $80, but you're gonna pay the CNA $75, okay, that's a different discussion. That's an absolutely different discussion than if you're paying only going to pay them $25 and you're going to charge $75. You're going to pocket $50, but you're going to take no responsibility, no workers' comp, no medical malpractice, none of those items. And the reason, by the way, that they should cover under medical malpractice is because nursing homes are determined to be a health care provider under the statutory definition of Chapter 538, which is where the medical malpractice statute is. So somebody has to cover that person for a medical malpractice. Thank you, Mr. Chairman.
Representative Smith.
Thank you for being here and testifying.
You bet.
You know, I wonder if, in a way, we're kind of throwing these staffing agencies under the bus, because it's like a lot of this information is presented and it's almost, it feels as if, you know, if these rates were the same, all these problems would go away and either just be accountability across the board, and, you know, if they were regulated, everything would be fine. But isn't it true that, I mean, we've got, I mean, I'm not an expert in the nursing home industry, but isn't there a lot of problems anyway with turnovers among not staffing agency employees, but just general nursing home staff? I mean, don't we have lots of turnover issues, accountability issues, even though they're regulated? I mean, if you search for complaints against nursing homes, I mean, you're going to find a lot of hits. I mean, surprisingly, a surprising amount of issues where staff members have been reported and they're continuing to work, or nursing homes. I mean, it's, if like every time there's a red mark against them, it kind of lights up the screen sometimes. And so I'm wondering if it's really a nursing home industry issue primarily, and if anything's really going to change. And I mean, I think that staff agency employees should be regulated. I mean, who doesn't? I think that's fair. But isn't this just a bigger problem with nursing homes in general, with turnover and just the poor treatment people are getting? And probably, I mean, a lot of it has to do with wages and, you know, Medicaid issues. I get that. But even if you paid everyone the same rate, aren't you still going to have a lot of these issues? And, you know, because I hear the stories about, well, these staffers come in and from these agencies, and, you know, there's a lot, they leave, they don't show up. But I mean, don't you really have that issue anyway with permanent employees at nursing homes? I mean, they're not showing up anyway. I mean, you don't have this idea that there's these dedicated long-term people who are making these very low wages and they're there and for the long haul, and it's really the staffing agency employees that are the problem. I mean, isn't it true though that it's rare to have these long-term dedicated employees with nursing homes? I mean, aren't they out the door a lot anyway?
Well, staff turnover in any industry is an issue, right? I will grant you that. I don't think that is unique to nursing homes at all. But no, yeah, you know, I don't know the answer to that because I'm not sure I've really studied one industry to the next and see which one has. But your point is well taken. I mean, I get what you're saying, and I think there's two pieces of that. Part one is how do you make that better, and I think part of it is, you know, better funding, and it's not just better funding because even those who are paying their own way in a nursing home, they're still on a fixed income, right? For the most part, most of these folks are still on a fixed income, so you can't really charge more necessarily. I think what we're saying is staffing agencies, from what I have seen, make the problem worse. And I don't think that we can say, well, because the problem was already kind of bad, making it worse, that's okay. That is not okay. And it's also not okay if they make it worse and they try to shun the responsibility that otherwise goes with placing employees or placing these folks into these types of settings. I think they absolutely have to at least adhere to all the responsibilities that an employer in a nursing home or a hospital would have to adhere to if you're going to actively recruit employees out of a facility. I think that absolutely has to be on a level playing field. So, but how do we make things better in nursing homes? I do think that, you know, better pay and always lowers turnover rate. There's no doubt about it. But better pay doesn't fix the staffing agency because they just charge more. It's what is X? X plus $1. That's their new rate.
Thank you. Other questions? Representative Ritchie.
Algebra. I always hated algebra.
Yeah, Jürgen, I missed at the beginning. Who were you representing on
Missouri
this?
Assisted Living Association.
Okay, gotcha.
Yeah.
To your knowledge, has there been an effort on the part of that group?
My association, you mean?
Yes.
Yeah.
Your association to sit down with these staffing agencies and say, listen, as a body here, we are dissatisfied with what you are doing, and we will collectively respond to this if you don't get some things sorted out, even if it means a short-term pinch to us. I mean, what kind of conversations have been occurring in that space, if at all?
Yeah, that's a good question. So I'm the lobbyist. I'm not the executive director. Let me find out, and also I suspect some of those conversations are not just at the association level, but also at the facility, because we also represent some facilities, some owners that have multiple facilities. That's what I'm trying to say, right? So that you have, so they kind of may approach those staffing agencies as a company-wide issue and not just facility by facility. But I'll check it out.
All right, thank you.
Thank you.
Next witness in opposition to the bill. Are there any other witnesses in opposition? Do we have more in favor of the bill? Can you raise your hand? Okay. All right, we'll take one more in favor of the bill.
My name is Shane McClain. I'm the president of Health Systems, a nursing home company in Missouri that operates 76 nursing homes. And I'm testifying in support of this bill. I'll try to speed through this. I don't want to repeat a bunch of stuff. Whatever you think about this pandemic, we can all agree it's been very tough on nursing homes. Most nursing homes have very reduced census and are operating deep in the red. Now that COVID is declining and hopefully becoming less of a problem, nursing homes should be able to increase census and stop the losses. However, that's not happening. Many nursing homes can't admit new residents, and the reason is not COVID. It's the inability to hire and retain staff. If a nursing home can't hire employees, they have to keep their resident census reduced in order to give good care. What is causing this inability to hire? It's partially because many have left the workforce, but I feel the main reason is the staffing agencies. In the first 11 years I worked for health systems, 2005 to 2016, we used staffing, the homes we work with used the staffing agency one day, and that was it, in 11 years. Last month, we used the staffing agency to a tune of $1.2 million. In normal times, staffing agencies provide a service that can help a staffing-challenged healthcare provider staff their building. It is never a permanent solution. It is a cancer. If you get it in your building, it's very hard to get it out, because then your other staff start leaving to go with them. Most businesses raise their prices to compete in the labor market. Nursing homes can't. Of the homes I work with, only 13% of the revenue is private pay. So you can't solve this problem raising the prices for those few people who are private pay. The other 87% comes from the feds and insurance companies. So raising prices on the private pay residents is not an effective way to compete in the labor market. Nursing homes, therefore, must rely on governmental payers to be able to afford employees. Last year, and hopefully this year, the state of Missouri has identified that nursing homes are underpaid and have increased the Medicaid rate. We're very thankful for that. However, nursing homes' expenses related to labor are skyrocketing and will not stop until staffing agencies are regulated. Some businesses limit their hours or close their doors for a day or two if the staffing is bad. Nursing homes can't do that. We can't shut the doors. There's people to take care of. This creates a situation where the nursing home is forced to use the agency and accept whatever the agency sends them. In one incident, an agency sent to one of our nursing homes a person who abused a resident. So the facility is totally responsible for that abuse. And this facility has been fined by the feds $115,000 for that agency person's behavior. Now, if that person had been hired by the nursing home had time to get to know him, well, then they could figure out, hopefully, that that person shouldn't be in a nursing home. If they got that kind of behavior, they're going to abuse somebody, they shouldn't be in the nursing home. That's the relationship a nursing home is able to build with people that they can hire and get to know. The agency people don't know the residents. You can't provide good care if you don't know the residents. So, staffing agencies are paying certified nursing assistants, LPNs, and RNs much more than what a nursing home can pay. Typical CNAs, $13 to $14 an hour. Agency pays them $22 to $30. Typical LPNs, $20 to $24 an hour. Agency pays them $32 to $36. RN, $27 to $32, while the agency pays them $40 to $45. We can't compete with that. How much does the agency charge the nursing home? On February 8th, I got a rate sheet, a new rate sheet, 30-day notice of an increase in prices. The agency raised their CNAs to 38 to 43 that the nursing home has to pay, 57 to 64 for an LPN, and 75 to 84 an hour for an RN, which is 2.5 times what we can pay. Another agency contacted the nursing home I work with. They raised their LPN $45 to $85 an hour with no notice. An RN $35 to $95 an hour. What is occurring now is that the agencies are battling for staff because they can't find it. So they're competing with each other and it just causes the wages to escalate even faster. The platforms, I thought the platform might be a good idea because I thought, well, maybe that'll be cheaper than an agency. It's not any cheaper than an agency. The platform that I'm talking about, $65 to $75 for an RN on typical conditions, but if it's a premium issue, then it's $115 an hour. Crazy high rate, not sustainable. We have a Medicaid system that was built based on a certain wage. And the state and the feds cannot adapt when things start going askew. This platform also requires that if they want to hire, if the nursing home wants to hire one of these people that's on this platform, between $4,500 and $8,500 fee. So, if you're charging that fee, are they really not your employee? It sounds like that these nurses are their employee. So, it's a disaster for the agency. When Nikki said 5 nursing homes have shut down since February 2nd, those 5 are ones I work with. It's a nursing home in California, Missouri, a nursing home in Minor, Missouri, a nursing home in Washington, Missouri, a nursing home in Willard, Missouri, and a nursing home in Springfield that we shut down since February 2nd. That doesn't include the 5 others we've shut down since the pandemic started and the other 10 that we've offloaded to other groups. So we're very helpful that the governor's budget recommendation to rebase nursing home rates is passed. However, if staffing agencies are allowed to continue to dominate the healthcare workforce, the increase in rates due to the rebasing will not even be close to helping nursing homes pay these insane rates. So in order to keep these nursing homes open for indigent elderly in Missouri who've got nowhere else to go and don't have any money to pay for anything, for the state to make us be able to compete with the agencies, the state's going to have to pay a lot more money. A lot more money. If the new norm is an RN getting $85 an hour, our rates are going to have to go up by $40 a day. Other states, say Arkansas, our friends to the south, they're no better than us. But they, in the nursing home industry, they pay $25, $30 a day more than Missouri pays. So they can handle this better than we can. So this has been a nightmare for 2 years, and it needs to end. But that's all I got. Thanks.
All right, thank you, sir. Representative Ritchie.
I appreciate the position that you're in, and we're all in this together trying to figure out how to find a solution. Just a real quick question on staffing costs. Okay, so if an RN on average in-house is $31 an hour, let's say, that's not the actual cost of that staff member. You have payroll taxes on top of that, and you have benefits, right? So what would be helpful in this conversation, in order to compare apples to apples, would be to identify the actual cost of that employee to the nursing home that our current Medicaid rates are not fully covering, but are being absorbed within the system that we have all inherited, right? So if, as is the case in the private sector, we always tell people, listen, you're not costing me $20 an hour. You're actually costing me $35 an hour in terms of all the additional, and then if it's a full-time employee, healthcare, insurance and dental insurance and whatever, right? Whatever the situation is. So it would be my understanding, correct me if I'm wrong, and I don't know that there's anyone else to talk to on the other side of this issue. If I am a platform or an agency and they are not an employee, this is like a headhunter type service that operates in other private sectors, executive headhunters. I mean, they'll charge a corporation, $50,000 or $100,000 to find a CEO type person. That doesn't make that person an employee of the headhunter. It's just we help to find them, and there's value in that. So if the agency or the platform is not hiring the person, they don't have the cost of payroll taxes, they're not doing withholds, they're not providing insurance, not providing any benefits, but that nurse making $60 an hour is paying self-employment tax, right? So all of that, when you start to calculate that, I wonder how much of a disparity there actually is my question.
Well, I think the platforms are pretty rare still. We haven't dealt with Shift Key but a couple times in the last 6 months. I found out about them last summer. So we're typically dealing with typical agencies, a lot of mom and pops that don't do benefits, but are doing, they're not 1099 employees. Yeah. They're true employees. So the the platforms really haven't got a huge.
So on the traditional agency, then you're saying they're being hired by the agency, and there are benefits then that they're.
I know of the bigger players that have benefits. The smaller players, okay. I know some of them don't.
Well, that would be interesting. Whoever out there would like to speak into that particular question I have, in order to get to an apples to apples comparison, because $30 an hour is not the true cost of that employee to a nursing home. It's a lot more than that. And to compare that to the actual cost of that person working for an agency, quote unquote working, or just offering their time to a platform, I just wonder if that disparity. Now, all that question takes nothing away from your consternation. I mean, your concern, your heartfelt concern, is absolutely legitimate. But I do think that if we have to resolve this, if we're going to be asked to resolve this, which I don't know that, if we're being asked to resolve this, we have to be able to say what is the actual cost, apples to apples. So,
Well, that's something we need to build up and provide you with more information.
Thank you. Representative Sauls.
Yes, thank you to inquire. Thank you.
Indeed.
So I truly see both sides of this issue, and I think that, my personal opinion is I don't think $14 an hour is sufficient for some of $14, $16 an hour. I mean, quite frankly, and I know this because I just researched this last week, but I mean, you could be a coffee barista in Kansas City and make $17 an hour. So, I'm approaching it from that perspective initially. I do, however, I'm just kind of curious, and I haven't heard this yet. Why can't some of this be contractually fixed, right? Like, provide a service, you have a need. Why can't, in the sense of this being that, I guess that's my first thought, because I understand the argument here that has been alluded by some folks that if someone doesn't come in, they don't do their job. I mean, I don't think that should be put on you. I think if they're providing a service and they come in and they don't show up for work, or they give bad, they tell us, I think somebody said they were going to die or something. I mean, if they're just bad employees, I don't think that should fall on you either. Is there some way to approach this contractually in the sense that, you both exist with each other? Do you see what I'm saying? So, like, is that a possibility, or what do we?
They hold the cards. They got the staff. We don't have the staff. We have to have the staff. And so, like, for example, if we try to hire their staff, we have to pay this money. And if we try to get that same provision in for us, like, so that if they hire our staff, they just won't give you any business. They won't provide you any service. They hold the cards. They're dancing on our graves. That's what they're doing. Sorry for that.
No, it's, if I, do you at least understand the I guess, what do you think would be a fair rate for CNAs and CMTs?
I think those healthcare providers deserve all the money.
Sir, can you talk into the microphone?
Sorry.
Yeah.
Those healthcare providers, CNAs, LPNs, RNs, they deserve great pay. The job is hard. It's not like flipping a burger, because they have to deal with, what people do who are helpless.
Right.
And so it really takes special people to do that job. So it comes down to the Medicaid rate. If we nowadays when we get a Medicaid increase, that money, it goes to the employees. We raise our rates, so in order to compensate them. And so it just takes increases in rates. Like I said, Arkansas pays a lot more, and they rebase every year. So your expenses for that year are taken in consideration for your rate for the upcoming year. And so that may allow for more free market if we're able to adapt somewhat to expenses that are out of control.
And I think that's a very good point. My grandfather it's been maybe 2 years now, but he passed and he was in a home, and there was one employee there at night, and it was at least in his wing, and I absolutely agree with you. I think they deserve better pay. I think they deserve more money. I think they're doing very difficult jobs, and I'm certainly in favor of anything we can do on our end to make it so that not into just fixing this problem, but quite frankly, I'd love to see these numbers moved up if we could do that. So. But I do appreciate your position. Thank you.
All right, thank you, sir.
Thank you.
Okay, we are going to finish up soon, so we'll take more testimony, but we're going to wrap up here. Witness in favor of the bill.
Good evening. I'm Gary Anderson. I'm the Chief Operating Officer of Lutheran Senior Services, representing the nonprofit side of the long-term care industry. I also would like to mention that I'm a registered nurse in the state of Missouri since 1984. I am speaking, I have a prepared speech, but everything that's in there is you've heard already. What I'd like to do is just add on a few things that were some of the answers. Again, we have made an effort over the past 2 years with the pandemic to reward our staff. During 2020, when we had a decrease and lost nearly $28 million, we still made a $3.8 million investment in our staff. And again, it was all in an attempt to make sure that they had a livable living wage. At the same time, we paid them over $1.3 million in crisis pay, staffing pay, to extra staff bonuses to get them to work during that time. Somebody had asked earlier, is this typical? It is not typical. This is not about what we're paying staff. I think that's the bottom line here. I applaud anybody that works for an agency to get more money. I understand that. What is atypical is the way the agencies are conducting business today. I put it in the same light as Hurricane Harvey during Texas, when people were paying $10 for some essential necessities. Our workers are not essential necessities. They are more than that. And this are some of the examples that I have, is that we have had agencies that we had worked with for years all of a sudden stopped sending us agency nurses, people that had been there on a regular basis. When inquiring, where is Susie Smith now? Oh, we found another person that will pay us more. And so they are reassigning that nurse that has been loyal to us. And so, again, you talk about mutual agreement. Can you sit down at the table with these people? You cannot. I'm telling you, I have attempted that as the chief operating officer, making sure that my residents have the care that they need. When I have sat there and I've seen an agreement that says, oh, if you want to hire this person, you're going to pay us $25,000. I don't know where this $8,000, $6,000, I haven't seen those. I've seen as much as $50,000. And I say, I will not pay that. They will walk out of my office and not agree to do business with us. So when we talk about free market, it's not a free market. Things have changed over the past 2 years with these agencies. And we talk about, is there problems with the industry as a whole? Yeah, we had 60% turnover. Significant turnover for us when we had been averaging anywhere from 30 to 35% turnover. The agencies are recruiting them away. When we do have an agency employee in our building, they actually are paying them a commission to recruit the people they're working with, our employees. How do I compete at 2 a.m. in the morning when somebody, hey, come work for us, and that person is going to get a commission because they recruited them away from us? So we talked about all these different, we talk about poaching, and I don't like using that word, but that is what's occurring. Their business model has changed significantly. And we talked about the turnover. You're looking at the gentleman that made the decision to vaccinate our workers. I lost 2.8% of my workforce. Out of 3,000 employees, I had less than 100 employees leave because they would not get the vaccine. That is dedication. That is commitment. I have 20 and 30-year-long employees in my organization. They are committed. And then when you get somebody like an agency that comes in and working side by side with these people that are not as committed, it hurts my morale. It struggles with that. But most importantly, and I don't want this part to be overlooked at all, it is the residents. These are our senior citizens at the end of their life. They count on that relationship more than anything else that they have with our staff. And when we do our employee surveys and when we do our staff, our resident surveys, the number one commitment by both sides is the relationships that have been developed. When you have an agency not show up or they send somebody else in their place, that relationship is damaged. That no longer exists in our building because of the fact they are not committed to giving us the same person from shift to shift. And again, these are employees that have been with us prior to the pandemic, and I do totally agree that the labor issue, this is a complex issue, the labor issues, the pandemic, all those things are playing a part of this. But when you say, is this typical? This is not typical. this is atypical for the way they are performing. When they walk out of your office, because you will not concede to pay a certain rate, or when they come to you when you have a 5-year contract and you're only 6 months in and they ask you, oh, we're raising the rates, we're going to, no, I'm not signing a new contract. All of a sudden, I don't see help from that agency anymore. They are manipulating the system.
All right, thank you, sir. Thank you. We're going to move on to the next witness. Is there anyone else left to testify in favor? Are we done? All right, thank you. Please proceed, sir.
Hi, Mr. Chairman. My name is Michael Levitt. I've worked in long-term care in Missouri for the past 4 decades. Held just about every position in nursing home we have. I'm a licensed administrator, have been since 1977 in Missouri. And I worked for the last 30 years for Tatera Senior Living and Healthcare, a Kansas City-based family-owned and operator of nursing homes. We own and operate 29 facilities across Missouri from every stretch: Kansas City, Liberty, Union, Aurora, Hannibal, Belton. And our experience with, when it comes to particularly, and I'm going to, if it looks like a duck, quacks like a duck, walks like a duck, it's a duck. The Uber platform model, particularly that's come into the market, which is ShiftKey, we've experienced that across the state. I will comment just on a couple things rather than go through my prepared speech, because a lot of this has been touched on. I will tell you, Representative Patterson, that our Monterey Park Nursing Home, which is in your home district, is a 4- and 5-star facility, has been for years, and we've enjoyed a great reputation in the market there with the people in Independence and in eastern Jackson County. In order to be able to meet the needs of our residents there, which again about 75% are Medicaid or Medicare, we do a lot of short-term rehab as well, plus long-term care. We actually spent, in my notes, which I would hand in here, shows that we spent $753,480 last year for agency. Actually, I called the accountant on my way down here today and said, hey, what did you finalize December year to date? What did we spend on agency? He says $815,450. To answer your question about true costs, just to kind of simplify that, should we have been able to recruit and pay people as our own employees, we still would have expended an additional, even if we had, all things being equal, we could have those people, we still would have spent another $136,000 to supplement that. Unsustainable, has been mentioned. So it's not just that. I certainly have some of the empathy for, I know, I believe it's Ms. Hamilton, Felicia talked about the agency, and I think we just have to draw a distinction. There definitely is a distinction between what some talked about, the existing traditional nursing agency firm, small to big. I've dealt with them for 45 years, from not ever having to see them for years to having to do a little bit to having to see a lot now. They're struggling against this platform. They are, as been mentioned, they are competing with each other. They are employees. Any other service I bring into that building, privately owned or otherwise, be it therapy company, equipment company, they all have a contract or an agreement with that facility, and it all includes providing workers' compensation, professional liability, and general liability. The platform is designed not to. It's all done online. There's no interview for platform employees. And the contract, and this is a difference, I'm not an attorney, but it seems to be you can't have it both ways. You're either an employer and you can set these things, or you have people who are independent contractors you have no responsibility for, so how can you dictate that you can collect money from them? So, and they collect all the money. So that's a huge conflict. The contract that the independent contractor, and this has been talked about tonight, I don't believe, with the platform agencies, 36 8.5 by 11 pages long. And it bases the independent contractor is responsible for this. The agency's not responsible. The platform's not responsible for this. It's just it's that long to basically isolate them from any liability. They leave that contractor out to hang. I think it's important when the realization some of these people may not realize come tax time, what their bill may be, or if they get in a situation where they have some personal liability, well, I don't carry professional liability. I thought the platform carried that for me. So these are some of the inequities that we can deal with, whether it's not a perfect bill, maybe it's too broad, maybe it's got too complex, but we can certainly, you know, like I tell a lot of my people who get frustrated some days about all the work they have to get done today, I said, hey, how do you eat an elephant? One bite at a time. We can do the same here. I thank you. I'll stop at this time, Chairman.
All right, thank you, sir. Thank you all for being here. Are there any witnesses here for informational purposes only? Do we have one over there? Yes, that would be great. Thank you. Thank you. We will continue the hearing next week. We will end today. Thank you very much for being here.